Okay. Good afternoon, everyone, and welcome to this training program, Day 4 training program. And today is Dr. Surbi Chandra from SRMS Bareilly will be the moderator for this session. So I welcome Dr. Surbi Chandra, and I request Mamta team to please allow Dr. Surbi to share the screen. She is not able to share the screen.
Hello, good
Sir can
afternoon.
share the screen now.
Okay, good afternoon, ma'am. Good afternoon, everyone. And thank you so much, ma'am, for this opportunity. This is the fourth last day of this week's training. I guess my screen is visible to everyone.
Yes, Surbi, it's visible and your voice is audible.
Okay, ma'am. So I'll be talking about septic shock in children. This is a dreaded complication of COVID-19 and it can be fatal also. So at the end of this class, we must be able to recognize what a shock appears like. We should have knowledge of different types of shock. We should be able to plan fluid therapy in different types of shock and also the vasopressor and inotropic therapy which is required in patients with septic shock. We know that shock is a state of diminished tissue perfusion. That is, blood supply at the level of tissues is decreased. That when the blood supply is decreased, then oxygen is also decreased. So basically, it is a state of tissue hypoxia. And this leads to an imbalance between the oxygen supply and the oxygen demand. This ultimately leads to inefficient removal of byproducts by the cellular metabolism. So sepsis is basically a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock, on the other hand, it is cardiovascular dysfunction which is associated with sepsis. Septic shock is a kind of circulatory and cellular or metabolic dysfunction associated with a very high risk of mortality. Now, the pathophysiology of shock I have already introduced in brief. Once there is inadequate perfusion at the level of the tissues, then what happens is that oxygen delivery is hampered. There is cellular hypoxia. This leads to deficit in the energy. It leads to lactic acid accumulation and fall in pH, that is anaerobic metabolism. Lactic acidosis is a kind of metabolic acidosis. This metabolic acidosis in turn leads to cell membrane dysfunction and failure of sodium pump, which in turn leads to intracellular lysosomal release and efflux of potassium and digestive enzymes. These toxic substances enter into circulation and lead to the various symptomatology of shock. And it also leads to capillary endothelial damage in various other organs of the body, finally leading to destruction of these tissues, dysfunction, and cell death. Now, shock has 3 stages clinically. One is the compensated stage. This is pathophysiologically and has clinical correlates. Compensated shock is the phase in which the body tries to compensate for the diminished tissue perfusion by its own mechanisms, for example, by increasing the heart rate, increasing the respiratory rate. It tries to maintain the blood pressure. That is, the blood pressure is normal in this phase of shock. Next is the decompensated shock. Now, suppose in patients with compensated shock, if you are not able to recognize patients in compensated shock saying that BP to theek hai, then in that case, patient might land up into the next stage, that is decompensated shock. And if you don't intervene even at this stage, shock becomes irreversible. That is, even if you intervene, the shock will not improve and it will lead to cell death. Now, basically, there are 4 kinds of shock: hypovolemic, distributive, cardiogenic, and obstructive. Hypovolemic shock, as the term itself indicates, it is decrease in the volume of blood which is flowing through the blood vessels. So what are the causes? The causes are GI losses, hemorrhage. These are the main causes, especially in patients with COVID-19. Then it is characterized by quiet tachypnea or silent tachypnea, tachycardia, hypotension or normotension with normal pulse pressure. The capillary ripple is delayed. Symptoms are altered mental status, oliguria, and cold extremities. The good part is that hypovolemic shock shows a favorable response to fluids. Obviously, when the volume of blood in the blood vessels is less, if you give fluid, the shock should respond. The distributive shock, on the other hand, pathophysiologically, you can understand that there is a kind of maldistribution of blood in the vascular and the extravascular compartment. That is, there is vasodilatation, and because of this vasodilatation, what happens is that blood extravasates from the intravascular compartment to the extravascular compartment or the third space. So what happens is that the effective circulatory volume inside the blood vessel, this decreases, and this leads to decreased perfusion of the organs. So the main types of distributive shock or the main etiologies are anaphylactic, septic, or neurogenic shock. Features are again the same, tachypnea and tachycardia, but you must remember that blood pressure here shows a wide pulse pressure. You know wide pulse pressure? Pulse pressure is systolic minus diastolic BP. Now, when vasodilatation occurs, for example, in distributive shock or septic shock, then what happens is that the diastolic blood pressure decreases, and this leads to an increase in the pulse pressure. And this is also the reason why bounding peripheral pulses are present. This is also the reason why capillary ripple is flash, especially in the initial stages of shock, in septic shock, which is referred to as the warm shock. But later on, if we do not intervene and it continues unabated, then finally the blood supply decreases so much that ultimately it leads to a delayed CRT and a cold shock. So warm flushed extremities is a feature of distributive shock. Other clinical features which will be seen in distributive shock are that of the associated symptomatology. For example, patients with sepsis, pneumonia, they have different features of respiratory distress. So these symptomatology will also be associated in patients with distributive shock. Now, cardiogenic shock, as the name suggests, it is caused by the inability of the heart to pump blood. So it is seen in intrinsic cardiac diseases, for example, myocarditis, cardiomyopathy, congenital heart disease, sepsis, arrhythmia, etc. And this will be manifested not by quiet tachypnea. This will be manifested by labored tachypnea. That is, there will be an increased work of breathing compared with hypovolemic and distributive shock. Then there will again be tachycardia. Blood pressure will show a narrow pulse pressure. Narrow pulse pressure, why? Because here the systolic blood pressure has come down. In the diastolic pressure does not remains quite slightly unchanged, but the systolic blood pressure decreases. That is why the pulse pressure becomes narrowed down. And the CRT is delayed. Again, altered mental status, oliguria, cold extremities are there. And then there is an adverse response to fluid challenge compared with hypovolemic shock. Why? Because if the heart is already failing and you are pushing more and more fluid into the heart, then the failing heart finds it all the more difficult to pump this extra volume of preload which you have given. So the fluid challenge will not have a good response in patients with cardiogenic shock. And finally, there is the obstructive shock. Obstructive means that the patient there is some obstruction in the forward flow of the blood from the heart. So this is seen in cardiac tamponade, tension pneumothorax, duct dependent lesions, and thromboembolism also. This is a slide showing the various changes in preload cardiac contractility after load, CRT, and mixed venous oxygen saturation in different kinds of shock. But important here to remember is that mixed venous oxygen saturation is not available. The facility is not available at every place, so it's not important. Basically, it is a marker of oxygen delivery at the tissue level. So it is low in almost all except in high in distributive shock, especially in initial phases. Now, coming on to the goals of management of shock. First, assessment of shock. To assess whether or not the patient is in shock, we have a small triangle. It is referred to as PAT or Pediatric Assessment Triangle and comprises of three things, that is A, B, and C. A is appearance, B is breathing, and C is circulation. So if a child has reduced muscle tone, decreased mental status, weak cry, poor responsiveness, purposeless or vacant stare, failure to recognize parents, and a poor response even to painful stimuli, you can think the patient might be going into shock. In patients with anaphylactic shock, there is effortless tachypnea, which we saw in the last slide, but stridor and wheeze might also occur because of bronchospasm. Then increased work of breathing is seen in patients with cardiogenic shock, septic shock with pneumonia, that is respiratory illness coexistent, and tension pneumothorax, which is a kind of obstructive shock. Circulation is suggested by cold extremities, mottled appearance, acrocyanosis, pallor. These are basically features of cold shock. Besides ABC, that is pediatric assessment triangle, we also look for the capillary refill time. If it is more than 2 seconds, you are sure that the tissue perfusion is being compromised. Flash capillary refill less than 1 second is seen especially in the early stages of warm shock. Blood pressure is not required to define shock in children, but it is an important marker. Why it is not essential to define? Because it remains normal in the compensated stage and it decreases only in the late decompensated and the irreversible stages of shock. So you must not define shock in children on the basis of blood pressure कि blood pressure तो ठीक है, बच्चा is not in shock. So you must not go by this route. Then altered level of sensorium and reduced urine output. It is one of the most reliable signs of internal organ perfusion. Why? Because urine output is an indicator of the perfusion of the kidneys. Now the early signs that is of compensatory stage of shock we all saw are restlessness, anxiety, irritability, slightly increased heart rate, normal or slightly decreased BP, pale and cold skin, slightly increased respiratory rate and slightly decreased body temperature. While the late signs are listlessness, apathy, confusion, unconsciousness, gross tachycardia, slowed, irregular, weak, steady pulse, decreased blood pressure, cold, clammy, pale skin, rapid breathing or slow, shallow respiration, confusion, incoherent, slurred speech, decreased or absent reflexes, and dilated pupils slow to react. If we have not intervened even at this stage, or even if we intervene at this stage, sometimes what happens is that this stage ultimately leads to irreversible shock and death. Now, how do you define hypotension in children? Hypotension in children is defined by the blood pressure, systolic blood pressure less than 5th centile of BP for that age and gender. Now, the cutoff can be remembered as the follows. In term neonates up to 28 days of life, from 0 to 28 days of life, if the systolic blood pressure is less than 60 millimeters mercury, then we should think that the patient is having hypotension. In age group 1 month to 12 months, systolic blood pressure less than 70. In the age group 1 to 10 years, systolic blood pressure less than 70 plus age into 2. And in the age group 10 years and older, systolic blood pressure less than 90 millimeters mercury is taken to be the cutoff for hypotension. So we have already seen how we clinically recognize shock in patients, in children. Even cold shock and warm shock we have seen, but just a revision. Cold shock, the peripheries will be cold, the pulses would be feeble, and the pulse pressure will be narrow. While in warm shock, the peripheries would be warm, the pulse pressure will be wide, and the blood pressure will have a wide pulse pressure. The capillary refill will be flash initially. Pulses will be bounding. Now coming on to the general principles of management, we see that shock is a state of diminished tissue perfusion and diminished oxygen to the tissues, that is hypoxemia at the level of the tissues. So our goal is to increase this oxygen delivery and decrease the oxygen demand at the tissue level. So for all children, we need to supplement them with oxygen, fluids, temperature control, and correction of metabolic abnormalities. And depending on the suspected cause, we also need to initiate antibiotics, inotropes, especially in cardiogenic shock, and mechanical ventilation if coexistent respiratory disorder is there. So as are the general principles of management, A, B, C, that is airway, breathing, and circulation need to be taken care of. Airway needs to be protected. Breathing always to be started with 100% oxygen and saturation to be monitored. For circulation, we need to establish an IV access rapidly, and if it is not possible, then we should go for intraosseous cannulation. I shall tell you further in this lecture how can we secure intraosseous fast, and then capillary refill monitoring and frequent blood pressure monitoring. We also need to do certain tests which are usually available at bedside, especially ABG, blood sugar, electrolytes, then complete blood counts, PT, APTT, INR, type and cross match in case we need blood transfusion, and cultures, of course, if we are suspecting septic shock. Now here we come on to the intraosseous insertion. Intraosseous, indications are if we are not able to secure a proper IV access. So circulatory access in cardiac arrest or decompensated shock if vascular access is not rapidly achieved, and we need to remove it as soon as vascular access has been established. So what we need is almost the same things which we need for an IV cath insertion, except for an 18 gauge needle with trocar. That is an intraosseous needle. Then material for local anesthesia and analgesia. We need to identify the appropriate site. Now, the most commonly used site for intraosseous insertion is the proximal tibia. Where in the proximal tibia? The anteromedial surface, 2 to 3 centimeters below the tibial tuberosity. Also, there are two other sites, distal tibia proximal to the medial malleolus and distal femur in the midline, 2 to 3 centimeters above the external condyle. We need to prepare the skin, insert the needle through the skin with a screwing motion perpendicularly and slightly away from the epiphyseal plate, because we don't want to damage the growth plate in growing children. And there is a giveaway feeling as soon as we enter inside the marrow cavity. Then remove the trocar and confirm the position by aspirating bone marrow. Even though bone marrow we might not be able to aspirate bone marrow every time, but at least the access should allow us to flush easily. Then we must secure the needle and start the infusion, which should preferably be manual with boluses with a 20 ml syringe. Now, the volume of fluid, we know that fluids are of two types. The fluid which has already been lost, which is referred to as deficit fluids. So once we start the management of shock, we start administering fluids, we first try to cover up the deficit, the loss which has already occurred. So the fluid which can be used are crystalloid fluids like ringalactate, normal saline, half normal saline, and colloids, for example, albumin, dextran, hetastat, especially in resistant kind of shock and in special cases. Then maintenance fluid is that which is required to replace the insensible losses. Now, what are the insensible losses? Insensible losses are the losses which we cannot sense. That is, we cannot see, we cannot touch. So these losses are the losses through the perspiration or through the respiration. The maintenance fluid is meant to replace the insensible losses and can easily be calculated by the Holiday-Segar formula. Now, what is the formula? Suppose we take a child whose weight is 22 kgs. Now, with this formula, we give 100 ml per kg for the first 10 kg weight of the child, which comes to be 1000 ml. 50 ml per kg for the next 10 kgs, that is up to 20 kgs, which comes to be around 500 ml, and 20 ml per kg for every kg beyond 20 kg, up to 30 kg. So at some places it is considered to be 25 kg. So this child is 22 kgs. So we'll give 20 ml per kg for the next 2 kg, which comes to be around 40 ml. So if we add 1540, it comes up to be 1540 ml. Now, the rate at which we need to administer the fluid. In hypovolemic shock, we give 20 ml per kg fluid bolus very rapidly, as fast as possible, over 5 to 10 minutes, and repeat as necessary. Up to what extent? In severe dehydration, we can give up to 100 ml per kg fluid in 2.5 or 5 hours, depending on whether he is infant or not. Albumin may also be considered for additional IV volumes for patients with shock, trauma, or burn as a plasma expander. In cardiogenic shock, what we need to do is that we need to give a small amount of fluid bolus and over a longer duration. that is bolus of 5 to 10 ml per kg compared with 20 ml per kg here, over 10 to 20 minutes whenever additional volume is required. But the thing is that the primary thing which needs to be used in cardiogenic shock is diuretics and vasodilators, because we need to help the heart to empty out the preload which is coming into it. And for management of obstructive shock, we need to give rapid and definitive care. For example, we need to do a needle insertion for patients with tension pneumothorax and all. What is important to remember here is that a patient may have more than one type of shock coexistent. Like most of the time, when the children they come to us, they are already ill for 2 to 3 days. So they have a volume deficit, that is, they have a hypovolemic shock. Along with that, they have developed sepsis and so on. So they have a septic shock. The heart might also be failing. So cardiogenic shock is also there. So many kinds of shock can coexist. So ultimately, it is the clinician who has to decide what not and what to do. Now, the three main types of the distributive shock are septic shock, anaphylactic shock, and the neurogenic shock. Septic shock, the management is very important, especially in the first 1 hour of recognition. This is referred to as the golden hour of management. So besides giving fluid, which we had discussed in the last few slides, we also need to give supplemental oxygen and correct hypoglycemia, hypocalcemia, administer antibiotics. Antibiotics is an emergency drug for patients with septic shock. We do need to administer them within the first hour. And we must also measure lactate because it helps us in guiding our therapy and prognostication. Then the management of anaphylactic shock consists of IM adrenaline and a judicious use of crystalloid fluids, whereas the management of neurogenic shock consists of 20 ml per kg bolus over 5 to 10 minutes. And in patients with severe acute malnutrition with shock, you have to have a word of caution because you cannot give rapid fluid bolus in them. Why? Because this will disturb homeostasis. They already have a lot of dyselectrolytemia and fluid depleted intravascular spaces. So what is recommended is that you give a volume of 15 ml per kg over a duration of 1 hour, and that too with strict clinical monitoring. The fluid which you should prefer in patients with severe acute malnutrition is ringolactate with 5% dextrose or 0.45 saline with 5% dextrose. Why do we add dextrose? Because these patients are slightly hypoglycemic, slightly or frankly hypoglycemic. So we do, and they're calorie deficient. So we do need to add dextrose when we are resuscitating patients with severe acute malnutrition having shock. Now, if patient of septic shock, you have an ICU facility, you can go up to 40 to 60 ml per kg. That is in boluses of 10 to 20 ml per kg per bolus over the first hour. But if ICU care is not available and there is no hypotension, obviously you don't need to give fluid bolus, but hypotension if present, you should go up to 40 ml per kg. You can go up to 40 ml per kg safely over the first hour, and must titrate the fluid amount to clinical markers of cardiac output, like we talked about the sensorium, the CRT, and the urine output, and discontinue if there are signs of fluid overload, for example, rales in the chest or hepatomegaly or slight tachypnea. And the fluid which you should use is ringolactate or normal saline, and starch and gelatin based fluids preferably should not be used for rapid resuscitation. The American Academy of Pediatrics recommends certain monitoring goals which need to be achieved in the initial hour of management of septic shock. First is the quality of the central and the peripheral pulses. They should be strong. The peripheral skin perfusion should be good. That is, the peripheries should be warm with capillary refill less than 2 seconds. Patient should have a normal mental status or normal consciousness. Urine output should be more than equivalent to 1 ml per kg per hour. The blood pressure, systolic blood pressure should be at least 5th percentile for age or more than that, which we had already seen in one of the previous slides. But remember, as already pointed out, blood pressure is not a reliable end point for assessing the adequacy of resuscitation, because in patients with shock also the blood pressure can remain normal if the shock is in compensated phase. The subsequent ICU goals needed to be achieved, which need to be achieved are normal serum lactate less than 2 millimole per liter. Target mean arterial pressure. Mean arterial pressure is systolic blood pressure plus 2/3 diastolic blood pressure or systolic blood pressure plus 1/3 pulse pressure. And the target mean arterial pressure has been defined by the formula 55 plus age into 1.5, the age in years. Then one must restore and maintain normal perfusion pressure, which is defined as mean arterial pressure minus central venous pressure, and SCVO2, that is central venous oxygen saturation of more than 70%. SCVO2 has been taken as a surrogate of mixed venous oxygen saturation, and both are the indicators of oxygen delivery to the tissues. So our goal in shock is to keep an SCVO2 more than 70%. Cardiac index should be greater than 3.3 and less than 6 liters per minute per meter square. Fluid responsiveness is defined as a rise in cardiac output as a result of volume resuscitation, that is, whenever we give fluids and the cardiac output has increased. Cardiac index, on the other hand, is a hemodynamic parameter that relates the cardiac output from left ventricle in 1 minute to body surface area. It is given by the form, basically it is cardiac output per unit body surface area. And we know that cardiac output is stroke volume into heart rate. Now coming on to the inotropic support in septic shock, the initial inotrope of choice in septic shock of the cold type, which is the commoner, and it is rather the late stage of every kind of shock. The inotrope of choice is epinephrine. If epinephrine is not available, then dopamine can be used safely as per the AHA 2020. But in patients with warm shock, that is in patients in whom vasodilatation has occurred, in them you obviously like to vasoconstrict or vasopress the peripheral blood vessels. So you would like to go for a vasopressor like norepinephrine. But regardless of the pathophysiology and the choice of agent, the peripheral inotropic support with epinephrine has been found to be safe for a very short duration. And it is recommended till you are able to achieve a central venous access. We know that all inotropes should preferably be given by central venous access, and if required, then you can give by the peripheral route, but in increased dilution. Adrenaline stimulates all the adrenergic receptors, increasing the contractility, heart rate, and systemic vascular resistance. In low doses, that is 0.1 to 0.3 microgram per kg per minute, it increases heart rate and cardiac contractility, but decreases SVR. That is the beta effect predominates. But in doses more than 0.1 to 0.3 microgram per kg per minute, this is a typing error, I guess. The principal action is on alpha receptors and it acts as a vasoconstrictor. So the dose of adrenaline is 0.05 to 1 microgram per kg per minute. This is an easy way of calculating the adrenaline infusion. If you want, I can tell you in detail as to how this weight in kg into 3 has come, but we'll take it in the question answer session if required. So if you prepare adrenaline infusion by this method, then 1 ml per hour of this infusion corresponds to a dose of 0.1 microgram per kg per minute of the child. Noradrenaline, we saw that noradrenaline is the agent of choice in warm shock. So mostly it is a pressor, that is a vasoconstrictor agent, and it systemic vascular resistance. Both systolic and diastolic blood pressure are increased because it increases the cardiac contraction also. It has minimal positive chronotropy due to reflex bradycardia, and it is advantageous in patients with intrinsic tachycardia. The dose is 0.05 to 1 microgram per kg per minute. Dopamine in a dose range up to 5 microgram per kg per minute activates the dopaminergic receptors and mainly causes vasodilatation in renal and mesenteric bed. In the dose range from 5 to 15 microgram per kg per minute, the beta-1 effect predominates, and this is the main dose range in which its inotropic action occurs. It increases contractility, heart rate, cardiac output, systolic blood pressure with minimal effect on diastolic blood pressure. But in doses more than 15 microgram per kg per minute, the alpha effect predominates. It leads to disproportionate vasoconstriction, leading to increased PPR at the expense of decreased cardiac output and markedly increased cardiac oxygen consumption. So the dose is 5 to 20 microgram per kg per minute. Dobutamine, on the other hand, is a synthetic compound. It has mostly beta-1 activity, increasing the contractility of the heart. The beta-2 effect is of vasodilatation. The positive chronotropic effect of dobutamine, chronotropy is increase in heart rate. The effect is less than that of dopamine. Hence, it increases cardiac output and improves perfusion and is basically used in patients with cardiogenic shock and obstructive shock. It has weak alpha activity, and dobutamine may be administered or added to vasopressor in presence of myocardial dysfunction or persistent hypoperfusion, despite achieving adequate intravascular volume and adequate mass. The dose range is 5 to 20 microgram per kg per minute. Then, if all this you have done and still you are not able to achieve blood pressure, then as a last measure, you can go for stress dose corticosteroids also, as per the American Heart Association recommendations 2020. The guidelines for transfusion of blood products are transfused packed RBCs when hemoglobin is less than 7 gram per deciliter in absence of extenuating circumstances such as myocardial ischemia, severe hypoxemia, or acute hemorrhage. Fresh frozen plasma can be given in documented deranged coagulation profile, that is increased PT-INR, and the presence of active bleeding, or before surgical or invasive procedures. Platelet transfusions can be given prophylactically if the platelet count is less than 10,000. They can be given in the absence of apparent bleeding when platelet counts are less than 20,000, or if the patient has a significant risk of bleeding, he is running febrile, he is sick, and for invasive procedures, surgery, for actively bleeding, you have to give patients even platelets, even if the platelet count is more than 50,000. Then, besides, you also need to manage hypoglycemia, that is blood glucose less than 180 milligram per deciliter, antibiotics, diuretics to reverse the fluid overload when shock has dissolved. Deep vein prophylaxis is not recommended in children. Prevention of stress ulcers and early enteral nutrition is promoted in babies, in children. To monitor a child with septic shock, we need to look for pulse, CRT, state of hydration, peripheral edema, core peripheral temperature gap, heart rate rhythm, hepatomegaly, JVP. We need to do a pulmonary cardiac auscultation, look for respiratory pattern, urine output, mental status of the child. Biochemically, we need to see serial glucose, calcium, lactate, electrolytes, blood urea, nitrogen, creatinine, liver enzymes, and CBC as deemed necessary. Non-invasive things which we need to monitor in patients with shock are non-invasive blood pressure, SpO2, ECG, chest X-ray, NICU, and USG. And invasive monitoring, which is present only in PICU and might not be present in all centers, is of invasive blood pressure monitoring, central venous pressure monitoring, pulmonary artery pressure monitoring, mixed venous oxygen saturation monitoring, and cardiac output. So the important take-home messages at the end of this lecture are that it is important to recognize shock in initial compensated phase and not wait for blood pressure to fall. Fluid therapy is the mainstay of early treatment in case of septic shock and hypovolemic shock. Careful monitoring is very mandatory to manage patients with shock. For warm shock, noradrenaline, and for cold shock, adrenaline is the preferred vasoactive agent. Thank you very much, and once again thank Professor Chandrakanta ma'am for permitting me to be the moderator for the session and giving me an opportunity to speak here. Thank you. I think the next presentation is by Professor Dr. Vikas Agarwal from Lala Lajpat Rai Medical College, Meerut. Sir, are you ready with the presentation?
Am I audible, ma'am?
Yes, sir.
Okay. Okay. I'll share my screen now.
Yeah, sure.
My screen is visible.
Yes.
Am I audible, ma'am?
Yes, sir. Yes, sir.
Thank you. Good afternoon, everyone. Before I start, I would like to convey my sincere regards to all organizing team for providing me platform to interact with the learned audience. It's a didactic 4 days training session on PICU COVID training. So now we'll be talking on one of the dreaded complication of COVID pneumonia, that is acute respiratory distress syndrome. So what are the learning objectives? The learning objectives are the definition of how to define pediatric ARDS and the severe COVID pneumonia in children. What are the lab evaluations to be done in severe COVID? What is the pharmacological treatment? How to provide respiratory support? The indications of mechanical ventilation in ARDS, and then lastly, what should be the ventilatory strategy for dealing with ARDS due to COVID. So this is a stereotypical clinical course of COVID-19, which is complicated by ARDS. On the y-axis, you can see the viral load, CT value is given, and on the x-axis, it is the number of days or the duration of illness. So from the inoculation of virus till the onset of symptoms is known as incubation period, and you can see the infectivity is at peak even during the incubation period, thereby meaning that even before the start of symptoms, if a person is exposed to COVID virus, that person can act as a spreader to other mm, persons. So once there is an onset of symptoms, there is an early phase which lasts up to 8 days. Now this is the phase where all the symptoms starts in the form of fever, cough, coryza, sore throat, loss of smell, and etc. So this early phase recognition is important because this is the phase where you are not going to use medicines like steroids or anti-inflammatory drugs like remdesivir, because this is a phase of infectivity. So this is the phase where the virus is multiplying. So here we have to just keep monitoring the patient's saturation, respiratory rate, and have a baseline investigations. Now, beyond 8 days, it comprises of an inflammatory phase or the pulmonary phase, where the inflammatory markers like CRP, D-dimer, ferritin, that rises exponentially. Now, this is the phase where the anti-inflammatory agents like steroids or if required remdesivir, steroids has to be used. Beg my pardon, in the first from 0 to 8 days, this is the time where you can use anti-inflammatory drug like remdesivir if required. So suppose the patient is very critical. So if you want to use a drug like remdesivir, it should be used in initial 0 to 8 days because that is the phase of viral replication. So remdesivir, a drug like remdesivir acts on the replication of a virus. It controls the virus multiplication. So this is the phase 0 to 8 days where a drug like remdesivir can be used, but beyond 8 days, its role becomes controversial. And after 8 days, where the inflammatory phase or the pulmonary phase, you should use steroids. So steroids should not be used in the early phase, and the remdesivir should preferably, if required, should be used in early phase and not in the inflammatory phase or the pulmonary phase. And then they have given the respiratory support if required. So respiratory support, we all know till now that we have to decide according to the need of the child, need of the patient. If it is mild and if the FiO2 requirement is low, you can use either nasal prongs or NRBM. If the FiO2 requirement is more, to achieve the target saturation, then we can use non-invasive ventilation like CPAP, BiPAP, HFNC. And if it is severe pneumonia or the FiO2 requirement is very high or the patient is not maintaining non-invasive ventilation, then we have to go for invasive ventilation. So I hope I am clear this slide. So now moving to the next goal, that is what is the definition of severe COVID in children. So severe pneumonia in children is defined as, that is tachypnea plus any of the following. If there is cyanosis or saturation at room air is less than 90%, or there is increased respiratory efforts in the form of grunting, groaning, or severe retractions, or the child is lethargy, or there is somnolence or seizures. So that fulfills the definition of severe pneumonia. Now they have added one entity, that is critical disease. So critical disease is uh, that a subset of severe disease, and it is defined as presence of one of the following, that is either ARDS or pneumonia with shock or pneumonia with multi-organ dysfunction syndrome, that is defined as critical disease. So how common is severe COVID in children? Now, this is the question which comes to our mind, because we have seen that in during the first wave and the second wave, the pediatric population was not affected much. And even if they were affected, they fairly remained asymptomatic and could be managed at home. So, in a systematic review where 7480 pediatric patients of confirmed COVID, uh, the systematic review was done, they found that 2% of children with COVID-19 developed severe disease that was in the form of dyspnea, central cyanosis, and hypoxemia. And out of these 2%, 0.7% were critical in the form of developing ARDS, respiratory failure, or shock. So this percentage 0.7 might seems very minuscule, but considering the huge population, pediatric population in our country, even this 0.7% will put enormous burden on our health facility. So that is why the preparations are going on in the form of training and uplifting the facilities with various equipments to tackle with the third wave in pediatric population. So when to suspect acute respiratory distress in children? So a child with COVID pneumonia, if there is progressive tachypnea or dyspnea, you must suspect that the child might be landing him into ARDS. If there is tachycardia along with diffuse crackles, if there is, if the child with respiratory distress or pneumonia also develops confusion or develops cyanosis or there is diaphoresis, probably the child is progressing toward ARDS. If on chest imaging you get an X-ray chest done, the alveolar infiltrates rising from below upwards involving more than 3 or 4 zones of the lung, again you must suspect that the child is progressing toward ARDS. If the saturation, oxygen saturation is declining despite of providing adequate FiO2, or if the FiO2 requirement, that is oxygenation requirement, is increasing to maintain the target saturation, then it must alert a clinician that probably the child is heading towards ARDS. Remember that the entity like silent hypoxia or happy hypoxia, which is seen in adults, is not encountered in children. The symptoms like cough, chest pain, wheeze, hemoptysis, fever, they are inconsistent findings in children heading towards ARDS. So we should not only rely on these symptoms to suspect ARDS. Now coming to the definition of pediatric ARDS. So before defining ARDS, we need what things we require to make the definition of ARDS. One is X-ray chest. Yes, we need an X-ray chest. Second, we need various oxygenation parameters to fulfill the definition of pediatric ARDS. SpO2, which we can derive from the multipara or pulse oximeter. PaO2, that we can derive from the blood gas. Then other parameters we have to acquire, that is FiO2, which is given there in either CPAP or BiPAP or even in invasive ventilator or HFNC. Then mean airway pressure, that we all can take from the ventilator console. So once these parameters we have to calculate certain values. We have to calculate PF ratio, that is PaO2 over FiO2 ratio, or we have to calculate SF ratio, that is SpO2 divided by FiO2. So if this PF ratio is less than equal to 300, we must say then that defines that the child is suffering from ARDS. Or if the SF ratio is less than equal to 264, then we say it is fulfilling the definition of ARDS. Then we have other parameters like oxygenation index, which is calculated as FiO2 into mean airway pressure divided by PaO2 into 100. These index like oxygenation index and oxygenation saturation index are calculated to categorize ARDS into mild, moderate, severe. So coming to the definition of ARDS, as I have told you that if a patient you calculate PF ratio, that is PO2 over FiO2 ratio, and it is coming less than or equal to 300, or SPO2 FiO2 ratio coming less than or equal to 264, it fulfills the definition of pediatric ARDS along with the X-ray imaging, which shows infiltrates consistent with the acute lung parenchymal disease. So remember, a child who is having severe pneumonia, X-ray finding suggestive of ARDS plus your PF ratio or SF ratio meeting these cutoff limits defines that the patient is suffering from ARDS. Remember that the insult should be within 7 days of the known illness. You have to exclude lung disease which are acquired, which are related to perinatal insult like haline membrane disease or uh, or BPD, that you have to exclude. Similarly, if the origin of edema is because of cardiac failure or fluid overload, that has to be excluded. So in nutshell, what you have to do is once there is a child of severe pneumonia, you will get an X-ray done. You will see the infiltrates. These infiltrates are usually either it will depict ground glass opacity, or there will be peripheral distribution of opacities which are usually rounded. The distribution is mainly involving the lower lobes, and then it ascends upward. Plus, if you will calculate PaO2 over FiO2 ratio, if it is less than equal to 300, that fulfills that the patient is suffering from ARDS. So once you have made the diagnosis of ARDS, or depending upon the oxygenation index, we have to categorize whether it is mild, moderate, severe. So if the oxygenation index is between 4 to 8, it is mild. If the oxygenation index is between 8 to 16, it is moderate. And if the oxygenation index is more than 16, it is severe. And how you calculate oxygenation index? This we have seen in the previous slide. That is FiO2 into mean airway pressure divided by PO2 into 100. FiO2 a map you get from the console of invasive ventilator, and PIP FiO2 you get from the device, and PO2 you get from the ABG. So this is how you calculate oxygenation index. Hope I am clear. If there is any doubt, we will take at the end. So what are the risks of pediatric ARDS? So we know if a child is on CPAP or BiPAP and requiring FiO2 more than 40% to attain a saturation of 88 to 92%, that must alarm the treating physician that probably this child is at risk of developing ARDS. So this is what does we mean by that? Suppose a child of moderate pneumonia and you have put that child on non-invasive ventilation in the form of a CPAP or BiPAP, and you find that the FiO2 requirement is increasing beyond 40% to achieve a target of 88 to 92%. That means that you have to be alert that probably this child may land up into ARDS and will require invasive ventilation to control the ARDS, because a patient of ARDS cannot be treated on simply on non-invasive ventilation. Oxygenation, uh, your oxygen requirement, the flow of oxygen requirement as per the age is more as given in this chart. For age less than 1 year, if your oxygen flow requirement is more than 2 liters per minute, one must alert. If between 1 to 5 years of age, oxygen flow requirement is 4 liters or more per minute, one should alert that probably this child will land up into ARDS. Similarly, between 5 to 10 years of age, if the oxygen flow requirement is 6 or more than 6 liters per minute, and in a child more than 10 years of age, if the oxygen flow requirement is 8 liters or more than 8 liters per minute, one must have to keep the probability of ARDS in his or her mind. So, in such cases, you have to fulfill the definition of ARDS. If fulfilled, that child should be intubated and taken over invasive ventilation. Now, coming to the management of severe COVID pneumonia and ARDS in children. So, I hope till now you are clear how to make the diagnosis of ARDS. Once you have made the definition of, diagnosis of ARDS, now how to manage it. So what laboratory investigations you required? You will send CBC if not sent earlier, liver function test, kidney function test if not sent earlier. You will send inflammatory markers like CRP, D-dimer, ferritin, procalcitonin. You will go for the gas if not done yet. And if done earlier, you will do serial ABG later on to look for the improvement. X-ray chest for confirming the diagnosis of ARDS or as one of the aid to diagnose ARDS. And these investigations can be repeated as per clinical condition or after 24 to 48 hours as per need. Now coming to the imaging, how you grade lung disease on the basis of X-ray. Now, if you can see here, the each lung field is divided into 3 zones. So the right lung is divided into 3 zones, upper, mid, lower, and similarly, the left lung is divided into 3 zones, that is upper, mid, and lower, and thus we have 6 zones. So depending upon the opacities present in the number of zones, the lung disease is graded. It is considered as mild if the opacities are restricted to 1 or 2 zones, and if the opacities are restricted to 3 to 4 zones, it is considered as moderate lung disease. And if more than 4 lung zones are involved, we say it is severe lung disease. And what kind of typical finding we get in ARDS? The opacities, they are multifocal, usually bilateral. These opacities are round in morphology, peripheral in distribution, and predominantly involve lower lungs. Now let's take this example. As you can see, this lung X-ray of this lung, if we divide this X-ray into 6 zones, we can clearly see that both lower zone opacities are present in both lower zone, both middle zone, and also in the right upper zone. So the only zone which is spared is the left upper zone. So in this X-ray, 5 zones are affected. That is, in 5 zones, opacities are present. So we have, according to grading, more than 4 zones if involved. So thus, this X-ray depicting that it is severe lung disease because the opacities are present in more than 4 zones. Hope I am clear. Now coming to the role of HRCT chest in evaluation of ARDS. So does HRCT is mandatory or required for the evaluation of ARDS? No, it is normally, routinely, it is not indicated. So what are the prerequisites? What are the indications of HRCT in ARDS? The HRCT in ARDS are indicated if you have a high suspicion of COVID but RT-PCR is negative. In such scenario, you need HRCT. Or there is an unusual clinical course, or you are suspecting fungal pneumonia. In such scenarios, HRCT is required. Otherwise, in a confirmed case of RT-PCR positive COVID case, HRCT is not routinely required for ARDS. And the prerequisites required to move such child to HRCT center, because that for getting HRCT done, the patient has to be shifted to radiology department. So such patient should be hemodynamically stable, should not be on high ventilatory settings, and should not be on HFNC or NIV, because you do not want to disturb the settings. Okay? So once the child is hemodynamically stable and there is an indication of HRCT, only in such cases HRCT should be advised. So what are the common findings, CT findings of ARDS? Ground glass opacities, consolidation. The consolidation is bilateral, peripheral in distribution, and mainly involves the lower lobes. Now, the ABG, as I have told you, is a important tool apart from clinical monitoring. Once you are managing a case of severe COVID pneumonia, the ABG shows hypoxemia. Initially, there may be respiratory alkalosis. Why respiratory alkalosis? Because the child is tachypneic, and when the respiratory rate is high, that leads to CO2 washout, and this will lead to respiratory alkalosis. And there is elevated alveolar to arteriolar oxygenation gradient, which is depicted by AADO2. Now, development of acute hypercapnia or respiratory acidosis is an ominous sign. As we say, when the tachypnea is there, once develop respiratory alkalosis. So despite of tachypnea, if the child is developing respiratory acidosis, that means the lung parenchyma is rarely bad. The compliance of the lung is bad. And that is an ominous sign that, that carries poor prognosis. So that must alert a clinical clinician that the child is on the worsening side. And metabolic acidosis, if present on ABG, represents either sepsis, shock, or associated with multi-organ failure or acute kidney injury. So metabolic acidosis should be dealt meticulously, finding out either the septic foci and to resolve shock if present. So what is the treatment of severe COVID-19 in children? You have to admit such child in PICU. Such child cannot be admitted in ward or cannot be managed at home. The respiratory support has to be provided either in the form of non-invasive ventilation, or you have to intubate the child and take on invasive ventilation. Steroids plus minus remdesivir, depending on which stage the child has come. If the child has come in the beyond 8 days, yes, steroids has to be used, or severe cases, you use steroids early and remdesivir if indicated and if required. Empirical antibiotics if there is associated sepsis, and you have to be restrictive on fluid therapy, because the liberal fluid therapy will worsen ARDS, will lead to fluid overload. So when to give remdesivir? Remdesivir is not routinely recommended by DGCI. So according to WHO, remdesivir, if required, the dose in 3.5 kg to 40 kg is 5 milligram per kg on day 1. And from day to day 5, we have to use in a dose of 2.5 milligram per kg. And for more than 40 kg, the dose is similar to that of adults. That is 200 milligram on day 1 and from day 2 to day 5, 100 milligram in OD dose, to be used within 10 days of onset of symptoms of and child is on oxygen. So as I have told you earlier also, that use of remdesivir beyond uh, uh, infective phase, that is in the beyond 10 days, is not useful. So ideally, the if it in the severe cases, it should be used early because it prevents viral replication. Okay. uh, Contraindications: if the ast alt level, upper level, is more than 5 times the normal, or if the your renal function are compromised, mm, remdesivir should not be used. And steroids, the dose, either you can use dexamethasone or methylprednisolone. If you are using dexamethasone, the dose is 0.5 milligram per kg per dose. Maximum you can give is 6 milligram in BD doses, that is twice daily. And for methylprednisolone, the dose is 0.5 to 1 milligram per kg per dose in 2 doses. And this is to be continued for 5 to 14 days depending upon the clinical condition of the child. Antimicrobials should be used judiciously only if you are suspecting infection, and you should not use high-end antibiotics. Uh, you can start with a baseline like amoxicillin or amoxicloxacinic or ceftriaxone. In severe cases, you can change antibiotic depending upon the blood culture reports. So the respiratory support, as I have told you, that will depend upon the available options and in the stage the child will come, and that will start from nasal prongs or shifting to simple mask or NRBM, and then into non-invasive ventilation in the form of CPAP, BiPAP or high frequency nasal oxygenation. And if the child is in ARDS or severe pneumonia, you have to intubate that child and take on invasive ventilation. Remember that during resuscitation, the target saturation is more than 94%. And once the child is stabilized, the target saturation is between more than 90% or between 88 to 92%. A child with severe pneumonia, consider awake prone positioning, which is possible in older children because it helps in better recruitment of alveoli and thus helps in improving the oxygenation. This prone positioning ventilation can be possible only in older children. So in milder a form of ARDS, the target saturation is 92 to 97%. In mild ARDS, you can give a trial of non-invasive ventilation like HFNO or CPAP or BiPAP. But if it is failing, even if the child is in mild ARDS, you have to intubate and put that child on invasive ventilation. And in mild to moderate ARDS, you have to intubate and take the child on mechanical ventilation, and the target saturation is between what you have to aim for, that is 88 to 92% of SpO2 and not beyond this. Now this is a very important slide where it is telling about the stepwise management of hypoxia. So if you require FiO2 between 24 to 44% of oxygen, which can be given by a flow of 1 to 6 liter, you should use nasal prongs. So if the FiO2 requirement is between 40 to 60% to achieve the target saturation, or if you require a flow of 5 to 8 liters, you can use facial mask. And if the FiO2 requirement is more than 60%, or and you require a flow of 10 to 15 liters, you can use non-breathing mask. And if the child requires higher FiO2 and not maintaining target saturation on NRBM, or there is respiratory distress, you should put that child on non-invasive ventilation in the form of HFNO or CPAP or BiPAP. And if the child is not maintaining on an IV or an IV is failing, and such child should be put on invasive ventilation after intubating. So the indications of intubation and mechanical ventilation we have discussed on many occasions, but just for the sake of revision, if there is severe respiratory distress with exhaustion, or if the sensorium of the patient is poor, GCS is less than 8, you know that GCS less than 8, the patient cannot protect his airway. So such child should be intubated and taken on invasive ventilation. Or if there is hypoxia, that is saturation less than 85%, despite of high use of FiO2, despite of use of non-invasive ventilation, in such cases also the child should be taken on invasive ventilator after intubation. In cases of severe ARDS, you have calculated PF ratio or SF ratio. It is showing severe ARDS. Then also, or in X-ray, the more than 4 zones are involved. Such children should also be taken on invasive ventilation. Or if there is respiratory acidosis or there is worsening despite of use of NIV, such children should be intubated and to be attached to mechanical ventilation. Now coming to the mechanical ventilation ventilator part, that now we'll be discussing what are the different types of ventilator, what are the controls, to give you an idea about ventilator. So we all know that the ventilators by and large are of two types: pressure controlled and volume control. Pressure control means that the pressure is fixed and the volume is variable. And volume control ventilator means that you have fixed the tidal volume and the pressure is variable to deliver that tidal volume which has been fixed by you on the ventilator. Now there are various phase variables. One is A, you can see that is a trigger. The trigger is either a pressure trigger or the flow trigger. Then B is the limit, whether the pressure or volume limit. Then the cycling could be either, most of the ventilators, they are either time cycled or flow cycled. And then the baseline, that once that cycling is either the time cycle or the flow cycle set is reached, the settings comes back to the normal. So these are various phase variables which you have to learn. Now coming to the settings on the mechanical ventilator. So once you have decided the control variable, either pressure control or volume control, whichever you are familiar with, then you have to select the mode. The mode, there are various modes, but today we'll be talking only about two. That one is SIMV and synchronous intermittent mandatory ventilation, and the other is assist control mode. Now, first of all, I will tell you the difference between the assist control and the SIMV mode. Now, the assist control mode, you can see that the bold lines, you can see up above the baseline, there are bold lines, and the second is the dotted lines. So the bold line means that all the breaths are supported by the ventilator. So what is the basic difference between assist control and the SIMV mode is, suppose there is a newborn and you have set a respiratory rate of 40 breaths. So these 40 breaths will be supported by the ventilator. Now, apart from these 40 breaths, if the child is taking 20 breaths more, ठीक है, suppose he is respiring at the rate of 60, तो 40 तो वेंटिलेटर ने सपोर्ट कर दी जो आपने सेट की, जो 20 है दैट आल्सो विल बी सपोर्टेड बाय द वेंटिलेटर इन असिस्ट कंट्रोल मोड. While in SIMV mode, the 40 breaths you have set will be supported by the ventilator. In between, whatever the spontaneous breaths which are indicated by the dotted line will not be supported by the ventilator. Am I clear? तो असिस्ट कंट्रोल मोड में सारी ब्रेथ्स, चाहे वो बच्चा ले रहा है या आपने सेट की हैं, वो वेंटिलेटर के द्वारा सपोर्टेड रहेंगी. जबकि SIMV मोड में जो आपने ब्रेथ सेट की हैं, उस टाइम पीरियड में अगर बच्चा ब्रेथ ले रहा है तो वो सपोर्टेड रहेंगी वेंटिलेटर से. उन दो के बीच में जो भी बच्चा ब्रेथ्स ले रहा है spontaneous, वो supported नहीं रहेंगी. So if the respiratory drive of the patient is poor, you should put that child on assist control mode. And if the child is having his own respiration also and you need ventilatory support, you can put that child on SIMV mode. Just as a basic, I'm telling you. So there is another mode, SIMV plus pressure support. So what here is done here, that the breaths, apart from the breath you have set, the spontaneous breaths which were not supported by the ventilator are now also supported. The pressure support has been given to that breath. And this happens in, if you have chosen pressure control mode. So in a pressure control mode, the spontaneous breath, apart from the rate you have set on the ventilator, will also be supported by the ventilator. That is pressure support. There is another mode, CPAP with pressure support ventilation. Just remember that this mode should not be used as initial mode of setting. It is a weaning mode. Just remember that this mode should not be used. So just forget about this mode. Just remember assist control mode and SIMV mode. The difference I have told you, that what is the difference between the two. Now coming to the settings, what knobs you have to set. So once you have selected the mode, that control, whether pressure control, volume control, then you have to select the mode, either SIMV or assist control. Remember, when you put a child on ventilator, you have to give analgesia, sedation, and even neuromuscular blockade if the child is very agitated. So this is the disadvantage of mechanical ventilation, which we have discussed when you have been taught about non-invasive ventilation. So tidal volume. So tidal volume, we usually start with 6 ml per kg. We have to be gentle on ventilation. So if you are using a volume control mode, so we will set a tidal volume of 6 ml per kg. Suppose the weight of the child is 10 kg. So we will set a tidal volume of 60 ml. Okay. This we have to set if we have selected volume control mode. So if we have selected pressure control mode, we will set PIP. So initial PIP will be 20 to 20 centimeter of water. The thumb rule is the guiding, I would say the mantra is that the PIP should be enough that you can see a visible chest rise. जितना आपने PIP सेट किया उस पे आपको विजिबल चेस्ट राइज दिखाई देना चाहिए. अगर चेस्ट राइज नहीं दिखाई दे रहा है, दिस मीन्स आइदर योर प्रेशर इज नॉट एडिक्वेट, or the tube is not in trachea, or there is some obstruction, or there is pneumothorax. So whenever you set a adequate PIP, there will be a reasonable visible chest rise. Then PEEP, remember that positive and expiratory pressure in case of ARDS is always set on the higher side. As you know, the function of PEEP is to recruit alveoli and to prevent alveolar collapse and atelectasis. So in ARDS, the alveoli, they are already in the atelectatic mode. We have to recruit the alveoli to improve oxygenation. So we start with higher PEEP. So we start with 8 to 10 PEEP and we titrate, we go up to 16 to achieve the target saturation. The disadvantage of higher PEEP is pneumothorax. So yes, we have to be very vigilant once we set higher PEEP. FiO2, we start initially on the higher side because we need to achieve the target saturation. Once the target saturation is achieved, we start decreasing FiO2 keep maintaining the target saturation. Respiratory rate we have to set according to the physiological range. Suppose our child is of 6 years, so we will set a ventilatory rate around 25 to 30. inspiratory time again in the physiological range, so that our IE ratio is into 1:2. Okay, sometimes in ARDS we have to reverse this, we have to even reverse this ratio, or we have to keep IE ratio even if it's to 1:1 or even reverse. So I'm not getting into that. Remember, the physiological ratio is 1:2. And always prefer cuffed endotracheal tube, because that will secure the airway and avoid aspiration pneumonia and decrease the incidence of ventilator associated pneumonia. Now, how to modify ventilatory settings based on the response. Uh, does it means? Suppose now you have made the diagnosis of ARDS, you have intubated the child, you have put that child on mechanical ventilation, you have selected the mode, you have done all settings. Now you have got an ABG done. ABG, you find that PO2 is below 50 and you want to improve oxygenation now, or you want to improve target saturation. So how you can improve target saturation? You can improve target saturation either by increasing TI time, or by increasing PEEP, that is positive end expiratory pressure, or by increasing FiO2. So by 3, you can improve oxygenation. Out of 3, the best is increasing PEE PEEP. Okay, and if you have to improve CO2 elimination, that is if the PCO2 is on the higher side, so either you can increase the respiratory rate or you can increase the tidal volume to decrease PCO2. So understood how to improve oxygenation and how to improve CO2 elimination, and what modification you have to do on ventilatory settings. So remember that once the child of ARDS on mechanical ventilation, we have to accept certain things. We have to accept permissive hypercapnia, that higher PCO2 levels we have to accept. So we have to be gentler, and we can accept pH of up to 7.2 or above. So PCO2 levels even high and the pH is above 7.2, it is acceptable. Then we have to ensure that the child is tolerating mechanical ventilation. We have to sedate the child. For sedation, we can use midazolam in the dose of 1 to 2 microgram per kg per minute, and we can titrate according to the clinical response. And for analgesia, we can use fentanyl infusion in a dose of 0.5 to 2 mics per kg per hour. And again, we have to titrate the dose depending upon the desired effect. And if the sedation and analgesia is not sufficient to keep the child tolerating mechanical ventilation, we have to use neuromuscular blockade. We can use vecuronium, norcuronium, or pancuronium, whatever is available at your facility. Remember, it is not used routinely and should be used only if sedation and analgesia alone is inadequate to achieve effective ventilation. So when to transfuse a case of ARDS on mechanical ventilation? So if the hemoglobin is less than 7, then only we should transfuse packed RBC. And if the child is septic shock and which is not unstable, then and hemoglobin level is less than 10 gram per deciliter, so these are the indications of blood transfusion. One is less than 7 gram per deciliter, another is in the septic shock, and if the hemoglobin is less than 10 gram per deciliter, right? And prone ventilation is to be preferred, and this, though it is difficult in younger children, can be tried in more than 12 years of age, as it improves oxygenation. Now monitoring is must. The monitoring, you have to monitor clinical monitoring in the form of heart rate, respiratory rate, blood pressure. Why blood pressure? Because you are on the higher PEEP, and you know that the high PEEP that interferes your venous return. So you have to look for the BP. Such children, they are already in shock. So you know that fall in BP is a late sign. of shock. Then saturation, consciousness, urine output, all has to be recorded every 2 hours or earlier if required. Lab monitoring every 2 to 3 times a day or NSOS basis, depending upon the clinical scenario. So remember that nobody can give you a blanket statement or a regime that only, okay, you have to do ABG this much time, 2 times, 3 times, or 6 times. This all depends upon the clinical scenario of the child. Then X-ray again on the SOS basis, and if the child is deteriorating, you suspect pneumothorax, then you have to get an X-ray done. But remember, to if you have suspected pneumothorax, clinically you confirm by reduced air entry, fall in saturation, or by applying the cold source, you will see increased elimination. And in such case, put in an ICD tube or needle. Don't wait for an X-ray to confirm your diagnosis of pneumothorax, because if you will wait for an X-ray chest to done, you may lose the child. And inflammatory markers depending every 24 to 48 hours as per the need. So ventilator monitoring, as I have told you, you have to look for the chest rise, you have to look for the retractions. Ideally, a child on ventilator, adequately ventilated, the retraction should not be there. The child should be comfortable. You have to look at plateau pressures. This is for the people, those who are dealing with ventilator. Plateau pressures is to monitor, to look for the compliance of the lung. Then minute volume, then alarm limits you have to look for, you have to set accordingly. You have to look for the circuit disconnections. Do not disconnect the circuit to do suctioning. Ideally, the suctioning should be in line to avoid disconnection. Sedation adequacy has to be ensured, and daily holiday from sedation is to be given for 1 hour to monitor the level of consciousness of the patient. Now, after this hectic lecture, let's see what we have understood. Let's take a case scenario. So that will make us more clear what we have learned till now. This is a 6-year-old girl who is 15 kg, has arrived in the emergency department. She is unwell for last 7 days. There is complaint of fever, cough, and progressive respiratory distress over 7 days. On examination, the child is agitated. The airway is clear. And the child is in severe respiratory distress. Look at the X-ray. You can see, if you divide this X-ray in 6 zones, what we have learned. So you can see both lower zone, both middle zone, the right upper zone, and also the left upper zone is involved. So almost all 6 zones are involved. So this is severe lung disease. SpO2 is 84 on high frequency oxygenation, and at 100% FiO2 and at 30 liters of flow. Even at such high FiO2, the SpO2 is only 84%. The heart rate is 170 per minute. Blood pressure is 100/68. We know in the previous lecture, Dr. Sapna ma'am has told you that a blood pressure for a 6-year-old child, what you have to do, you have to calculate according to PALS guidelines, age in years into 2 plus 70. So this child is 6 years, 6 into 2 is 12, 12 plus 70 is 82. So the systolic blood pressure is okay. Peripheries are warm, and the blood gas pH is 7.47. It is okay. PCO2 is 30. So that is alkalosis because the child is hyperventilating, and the PO2 is 50. That is towards hypoxemia. So by looking at this clinical scenario, it is well known that this child is a case of ARDS. By looking at the X-ray, and if you calculate SF ratio, the SF ratio in this child, if we calculate, will be, can anybody can write in the chat box what will be the SF ratio in this child? The SF ratio, that is SpO2 is 84 divided by 1. 100% we will take it as 1. So that will be 84. So 84 is the score SF ratio, and SF ratio less than 264 is ARDS. So this is a case of ARDS. According to SF ratio, according to X-ray, according to clinical scenario. So our diagnosis of ARDS is made. Now, what initial clinical settings in ventilatory settings we will do in this child? We have selected volume control mode. We have taken the child on assist control. Tidal volume, as I have told you, we select by 6 ml per kg. The weight of the child is 15. So 15 into 6 is 90 ml. So we have set a tidal volume of 90. PEEP is we have taken 16 because the SpO2 is very low, 84%, even at 100% FiO2. Respiratory rate, I told you, 6 years, anywhere between 25 to 30. TI time into physiological range, FiO2, we have started from 60%. You can start from 60 to anywhere 100 to achieve the target saturation. A good sedation analgesia without muscle relaxation has been done to provide adequate ventilation. We have to keep a monitor on P plateau. Okay, this is how we have put this child on mechanical ventilation after making the diagnosis. Now, how to wean this child? Now, weaning this child, well, once the parameters improve, the target saturation is maintained, we have to decrease PEEP as well as FiO2. So we will decrease PEEP, we will come to the lower side of the PEEP and as also FiO2. Once these are reached, lower side of PEEP and FiO2 is reached, and then we will start decreasing the ventilatory rate. Once the gas, clinical scenario, the target saturation, everything is achieved within the normal range, then we can wean this child either on SIMV or we can put this child on TPs for some time and then can extubate accordingly. So this is how we wean this child and extubate. This all the mechanical ventilation weaning is an art which cannot be learned in a single lecture. Once you will start using ventilator, once you will become familiar with the settings and the clinical scenarios, gradually this art will be learned. So this is the overall flow diagram of the management summary of severe pneumonia due to COVID, right? So what is the take-home message? Focus on the basics. Steroids, remdesivir, low molecular weight heparin, they are not miracles. They have to use in the right patient and at the right time, which is the trick. Ventilation is the blend of art and science, which has to be learned over time. Spend time with the patient, spend time with the machine. We have to ventilate the child gently. We have to accept hypercapnia. We have to be gentler on the tidal volume. We aim for the acceptables, not for the normals. And communication with the relatives is of utmost importance to avoid chaos later on, because we know that even in best of the best PICUs, ARDS has worse outcome. The morbidity and the mortality because of ARDS is very high, even in best of the best nurseries. Those who are interested, there is additional learning material available. My sincere gratitude and thanks to all the contributors for making this module. Thank you all the participants for the patient listening. Madam, if there is any question, I would take it up to the moderator.
Thank you, sir, for the very lucid talk. Thank you, sir, for the very lucid talk. And many people in the chat box are saying thank you to you, but I think no one has raised any query.
Okay, ma'am. Okay, ma'am.
So with this, I think we can break for the lunch break. We will break for 20 minutes. It is around 1:35. We'll meet at 5 minutes to 2. Thank you, everyone.
Hello, Dr. Aisha.
Yeah, hi, hello.
So lunch time is probably over now, so
Okay,
you may please start.
okay then. I'll share the slides then. Can you see the slides? Can you see my screen, please? Okay. So okay, you can see. Thank you. So do I start now? Okay. Okay, thank you, Dr. Rita. Thank you so much. So I welcome all the, okay, thank you, Dr. Jyoti. You can hear me, you can see me. Okay. So welcome all the participants to this post-lunch session on MISC, that is multi-system inflammatory syndrome in children. So as far as COVID is concerned, fortunately, all of us did not get to see many cases of COVID in children, but we were baffled by the unusual presentation of cases. They presented like they have cardiovascular involvement, some presented like Kawasaki disease, but not the typical variety. So these cases continued to baffle us, and subsequently these cases were diagnosed to be a case of multi-system inflammatory syndrome. So this is a manifestation of COVID, which was very commonly observed in children, and especially in the last few months, in last couple of months, we got to see a lot of children. We had sort of outbreak of children presenting with MISC. So that is the reason why this topic has been chosen for today's talk. So for this talk, the learning objectives would be when to suspect MISC and what are the clinical features, how to suspect MISC in children, what are the typical features, the clinical manifestations, how do you stepwise evaluate a child who is suspected to be a case of MISC, what are the definite criteria for diagnosing such children, and followed by how do you manage such children. So coming to the definition, what exactly is MISC? So it is a novel multisystem hyperinflammatory syndrome that follows exposure to SARS-CoV virus by 2 to 4 weeks and affects children and adolescents. So the important point here is that it's an hyperinflammatory syndrome. That means the children, apart from having inflammation, they mount an hyperinflammatory response. That is the reason that they can have audible. Is it audible? Is there any issue with the voice? Can you hear me? I hear
it's audible. It's audible.
It's audible. Okay, then I'll go ahead. So it's hyperinflammatory syndrome that follows exposure by 2 to 4 weeks. So it's not that the child has acquired and he has those symptoms. So it is sort of post-COVID. There is hyperinflammatory response after the child has acquired COVID infection. So this is something which is post-COVID, and it predominantly affects children and adolescents. Though we have seen cases in MIS-A like in adults as well, but children, they mount this response, and this MIS is seen more commonly in children. It was first reported from UK in April 2020, and it was the beginning when they start suspecting that those children, even we observed in India, like we had a lot of children who presented with cardiovascular involvement, whom were suspected to be a case of Kawasaki disease, but they were not qualifying all the criteria of a typical Kawasaki disease. Then subsequently, it was temporal association was found that such children, they had history of exposure to COVID, and they had COVID antibody positive. This could be positive, could not be positive, as I'll come to it. But these children had actually hyperinflammatory response, which you see in children who have been exposed to COVID. So how common is MIS? So fortunately, it's not common. It was seen in less than 1% of all COVID-19 infection in children. But if you consider the number of cases, we did see an outbreak in the last few months. In our setup, we saw about cases as close to like 45, 50 cases in 2 to 3 months. But if you compare it to the proportion of total COVID cases, then definitely children having MIS is less as compared to the total cases that we encounter. And another thing is less than 10% of children, they required hospitalization. Okay, so COVID is fortunately not so problematic in children, but in certain proportion of children who have a huge inflammatory response, very intense inflammatory response, they might require ICU care as well. So what causes MIS? So the exactly pathogenesis is not very nicely understood. So it remains the new idiopathic. So it can be diagnosed in children who had proven COVID infection or who had a history suggestive of exposure to any COVID positive person. Then the postulated probable mechanism of inflammation, why this inflammation is more intense. So it is perhaps the postulated reasons are, it is perhaps because of immune dysregulation, it is because of more antibody formation to the viral pathogen, as well as T cell mediated. So we have both humoral and cell mediated immunity, which becomes hyper responsive to this COVID infection, and the child has manifestation of MIS. So again, the pictorial description of the same. Once you have a child who gets infected with SARS infection, most of the children, they remain asymptomatic or they remain mildly symptomatic. So the virus gets lodged in the nasopharyngeal space, and for reasons like ACE inhibitors, receptors are not very commonly seen in children. So the lower respiratory tract infections are not very frequently seen, but this colonization leads to stimulation of both the prongs, the both pronged approach, both helper T cells as well as B cells. So these cells, once activated, as you can see here, they lead to antibody formation. The plasma cells are activated, they lead to antibody formation, and simultaneously these T cells, once activated, they tend to increase the interleukins, the interleukin 1, interleukin 6, and the chemokines, they are they are secreted in the bloodstream, and they lead to what is known as cytokine storm. So this altogether release of excessive amount of cytokines leads to a condition which causes hyperinflammatory syndrome. So it leads to again reactivation of and colonization and activation and recruitment of more macrophages, more neutrophils, and they cause all the damage. So all these B cells as well as activated T cells with all the inflammatory markers, the inflammatory parameters, they lead to the pathogenesis. They lead to this syndrome known as MISC. And how does it manifest? So it can, because it's an because of immune dysregulation, so it can present in any form. It can mimic any common disorder. It can have CNS involvement. The child can present with hepatic involvement. The child can have mucocutaneous manifestation. This is the reason why these children were being confused with Kawasaki, whether it's simple Kawasaki or COVID has got something to do with it. Whereas direct viral invasion causing damage in children is not established till date. So it's like children have the manifestation, which is an immune hyper response to the virus. So coming to the same thing again, so there can be two scenarios. Some children, they present with MIS, but not all of them present like this. Some, even after getting infection, they recover without having any features of immune dysregulation. So what actually has been postulated that in children who have a low viral load, so as you can see here, the viral load is low, and simultaneously there is production of interferon, there is production of chemokines, there is production of interleukins, and as the child improves gradually, the child recovers from this infection, the viral load gets reduced, and there is production of seroprotective antibodies. And this response, though that is present, but it is something short-lived. So it gets better as the viral load, the child clears himself of the viremia. So these are the children who present with a mild disease. They have milder manifestation vis-a-vis compared to those children who have a severe disease, including this MIS. So what happens in such children? Their viral load is more intense, and it leads to more intense response of interferon, be it in chemokines and interleukins. So all the inflammatory markers, they are produced at a later stage, but the response is very intense and prolonged as well. So they mount a very, very intense, very severe response. They have more production of inflammatory parameters, and it persists for a longer period of time. So these are the children who have low viral clearance, and they are more prone to have severe presentation, including MIS. So what can be the clinical features of MIS? As I said, such children, they can present, it can mimic any systemic disorder, thereby adding to confusion. So children, they may have myalgia, they can have a presentation of Kawasaki, like they can have mucocutaneous manifestation, they can have rashes, they can have non-purulent conjunctivitis, then they can present like meningitis, they can have a meningitis-like picture, they can have headache, meningismus, lethargy, even seizures. They can present with hepatic failure with all the features of hepatic derangement. They can present with acute gastroenteritis, and that was even our observation that most of our children who were subsequently diagnosed at MISC, they had cardiovascular and gastrointestinal involvement. So you can get confused with any of the system. The child can present with any symptom involvement, any system involvement, along with certain biochemical parameters. There are certain clues which can help you come to a definite diagnosis. So if you can see in the picture here, so the child can present with strawberry tongue, he can have cracked lips, he can have non-purulent conjunctivitis, then the maculopapular rash, which is characteristically seen in Kawasaki. So children who have MISC, they may have mucocutaneous manifestation as well. So what can be the clinical spectrum of MIS? So it can range from mild to severe. So about roughly 1/3 of cases are caused by class 1, 2, and 3 each. So out of these classes, the class 1, which is very commonly seen and which was our observation in our hospital as well. So they mount an hyperinflammatory response. More than one system has been involved, and 98% and close to 100% of the children, they had a positive serology. That means they had antibody positive. And they had a cytokine storm and all the manifestation. And in most of the children, like in here, you can see almost 100% of the children, they had predominantly either cardiovascular system involvement or gastrointestinal system involvement. So this is the type 1, class 1 of MISC. Then another class coming to class 3, again, which contributes to about 1/3 of the total cases. They presented with Kawasaki, incomplete or atypical Kawasaki. Age was around roughly 5 to 6 years, and 63% of them had serology positive. And about 34, 1/3 of them, they had both serology as well as antigen RT-PCR positive. But fortunately, in both the cases, the class 1 as well as the class C cases, the mortality is low. So they have morbidity, but if you provide them timely care and support, then most of them, they respond to treatment. And fortunately, as of now, what future holds for them, what future long-term complications and morbidities in terms of cardiovascular they can have, it's not known because it's too early to say. But as of now, the mortality has remained fortunately very low, but they need to be followed up to be able to predict what complications, whether they can, like in a simple Kawasaki disease, they might have coronary abnormalities later in life. So it's not known for MIS as yet, but if we follow such children, then definitely we can have a better picture. Then the class 2nd, this is the class in which there is confusion because such children, they present with respiratory system involvement. They can have presentation with like ARDS, they have myocarditis, and they can be easily confused with fresh COVID infection. So it's either it's a post-COVID hyperinflammatory response or it's a fresh acute COVID infection. So that's the confusion here, because an 84% they may have RT-PCR positive as well. And the mortality, and this is the class in which the mortality is the highest, about close to 5% of all cases of MIS. So what are the clues? How can you differentiate whether this child has acute COVID infection or he has this MIS? So there are certain pointers in the history as well as certain biochemical pointers which can help you in arriving whether this is MIS or this is severe COVID. So as I said, most of the cases who presented with MIS, they had predominantly gastrointestinal involvement and cardiovascular involvement. And as far as cardiovascular involvement concerned, they had more of left ventricular dysfunction, they have more of myocarditis and coronary artery abnormalities. And most, if you compare to COVID cases, most children who had MISC, they had mucocutaneous manifestation. They may have, they may not have, but the probability of having mucocutaneous inflammation, inflammatory markers and signs was more in MIS as compared to COVID-19. Whereas children who had COVID, they have more presentation of respiratory system involvement. They had more features of respiratory failure and ARDS. And as far as, though this is not a hard and fast rule, but this is usually the observation, which the observation has been that MIS cases, they presented more with GI and cardiovascular, whereas COVID cases, they have more involvement of respiratory system. And as far as biochemical parameters are concerned, there was the observation is that the children with MIS, they have leukocytopenia with relative neutrophilia. So the total counts were reduced, but the absolute neutrophil counts, the proportion was high, and they had more elevation of CRP as compared to the COVID cases. So this can give you help in. And as far as MIS versus Kawasaki disease, so MIS, it had broader age range. We had children from 6 months of age to adolescent who presented with MIS, and they had features, atypical features of Kawasaki disease. Again, they had more of prominent GI symptoms and neurological. They presented with aseptic meningitis as well, with hepatic failure as well. They may and may not have mucocutaneous manifestation, whereas in Kawasaki disease, you should have mucocutaneous manifestation. They presented more frequently in shock, and they had cardiac arrhythmias. They had evidence of myocarditis. They had lower platelet counts, while you tend to see higher platelet counts in Kawasaki disease. And they had absolute lymphocyte counts with a relative increase in the neutrophils, and they had high CRP levels as compared to the Kawasaki disease. But whether these MIS cases are going to have coronary abnormalities like other Kawasaki disease, it's not known as of now. And maybe a few months or even maybe few years down the line, we can have a better idea whether they are behaving as Kawasaki with residual cardiac dysfunction or not. So how to investigate a child whom you suspect to be a case of MIS? So if you have a suspicion, like if you have a child who has fever more than 38 degrees for 3 days, he has a clinical feature suggestive like involvement of any more than one organ, And you have an epidemiological link, which was being, like, especially during the second wave, this was something which was seen in all the cases because everybody had exposure to SARS infection, SARS-CoV infection. So this was something which was observed in each and every case. If the answer is yes, all the three parameters are met, then you have to look whether the child is in acute life-threatening event or he is in a relatively stable position. If he has any features of multi-organ dysfunction, he presents in shock or neurological involvement, if yes, then you have to subject the child to both tiers of investigation simultaneously. You have to start the child on treatment, and simultaneously you have to look for other causes. You have to look for other tropical infections. If the answer is no, though you have, that means you have suspicion, but the child is in a relatively stable state, then you can subject the child to tier 1 investigation first, and if it comes out to be positive, then you can get the second level done. Okay, so what constitutes tier 1 investigation? So I'll come to it. So as far as clinical features are concerned, out of these 5, at least 2 must be present. That means the child should have a rash or non-purulent conjunctivitis or any features of mucocutaneous inflammation. The child has hypertension or presents in shock. He has evidence of myocardial dysfunction, pericardial involvement, and any coronary artery involvement. And along with this elevated biochemical markers like TROP-T and BNP, and there is evidence of coagulopathy with the deranged PTA, PTT, and D-dimers, and acute gastrointestinal problems. So in all those, if you have out of these 5, at least 2 positive, then you should suspect MISC and go for further investigation. So what constitutes tier 1 evaluation? Once you have either a strong clinical suspicion, you have this epidemiological positivity to SARS-CoV infection and all the clinical manifestation, then you should get these investigations, the level 1 investigations done, which means a complete blood count and a metabolic profile that includes a liver function test, kidney function test, a blood gas analysis, blood glucose, and serum albumin, and CRP and ESR to corroborate your finding. And you have to go for SARS-CoV serology and or PCR. Serology is really important, and you can have PCR, especially in the type 2 class 2 cases positive. So what constitutes a positive screen? If the levels of CRP is more than 5 mg% and ESR both have to be positive, and at least out of all these 5, at least one of this is positive, where you have absolute lymphocyte count less than 1,000, you have platelet, you have thrombocytopenia less than 1.5 lakhs, you have a hyponatremia, hypoalbuminemia, and with a relatively neutrophilia. So presence of at least one of these, that makes your tier 1 investigation screening positive. So if one is positive, if the child is stable, the tier 1 investigation comes out to be positive, you get second level investigation, tier 2 evaluation. So that consists of a cardiac evaluation where you have to get ECG done and echocardiogram and certain biochemical parameters like proBNP and troponin done. You have certain inflammatory markers, which includes procalcitonin, PTA, PTT, D-dimer, fibrinogen, LDH, and cytokine panel if available, and a blood smear. So you have to get these investigations done to further confirm your diagnosis. And what is a positive screen? So if in ECG you have evidence of left ventricular dysfunction, you subject the child to echocardiography. You have ejection fraction less than 35%, and with evidence of left ventricular dysfunction, you have coronary artery abnormalities, especially if it's dilated more than 20%, and the Z score that is calculated. So anything more than 2.5 Z score, and you have evidence of pericardial involvement or conduction abnormalities. So any abnormality in your ECG and echocardiogram, so you get this proBNP and TROP-T done. Then positive inflammatory markers, D-dimers, if it's elevated more than 5 times or absolute value, it depends upon the lab. So more than 5 times of the lab values, a deranged PTA, PTT, high fibrinogen levels. So you should suspect MISC, and the general blood picture may show schistocytes and percents. So that constitutes a second positive tier 2 screening. So there have been many recommending bodies which have come up with diagnostic criteria for MISC, how to classify MISC. So this is the WHO criteria which we have been using. So it says the child's age, it's commonly in between 0 to 19 years of age. There should be presence of fever for at least 3 days above 38 degrees Celsius. There should be more than one organ system involved. there should be evidence of inflammation in the form of inflammatory markers, which means ESR, CRP, or procalcitonin are high. And this is the most confusing criteria, exclusion of other diseases. So at times it becomes difficult. So in all the cases, if you suspect MISC, because they can mimic any systemic involvement, so you should send relevant investigations to rule out any tropical infection which might get confused with MIS, and epidemiological link with SARS infection, coronavirus infection. So you have to subject the child to serology, RT-PCR. You have to find history if there is anybody positive with COVID infection, and you have to exclude other common infection, whichever infections are more common in your setup. You have to exclude those infections before labeling a child as MIS. So what it boils down to is that no single diagnostic laboratory test for diagnosis. So there is no single test which is sensitive enough that this test is positive. So this child, because CRP, D-dimers can be seen in other infections as well. So at times it remains very challenging, but if you have strong clinical suspicion, if you feel this is MISC, then definitely, and the child has any life-threatening complications, so you should not wait for the reports of the results, lab results, but you should start the treatment. And as you have the better picture, as the time passes and you have reports available, then you can take a call. So how do you manage a case? So that management depends upon whether the child presents in acute life-threatening state or in a relatively stable state. So what are the rationale behind which you start management of a child with MIS? So you have to manage this hyperinflammatory state because this is the known pathognomic feature of MIS. So you have to start on immunomodulator, which includes IV immunoglobulins, which includes corticosteroids and interleukin receptor antagonists, which are not very easily available in Akindra. Then you have to manage because there is a procoagulant state as well. The child can have, and to add to that, he has coronary abnormality, he has left ventricular dysfunction, so he can have thromboembolic phenomena. So you have to put the child on antiplatelet drugs and aspirin and low molecular weight heparin if the need arises, along with the supportive care. So most of the children, if provided this supportive care along with this definitive care, they respond very well to treatment. So how do you judge? You have a child where you suspect MIS. So you have to look whether the child has any evidence of life-threatening event, like he has cardiac dysfunction, he has coronary involvement, he has multi-organ dysfunction. If it's yes, then you don't have to wait because the child won't give time. You start him on methylprednisolone and IVIG at the dose of 2 grams per kg IVIG and methylpred in the dose of 1 to 2 milligram per kg per day. So this IVIG has to be given over a period of 12 to 16 hours. But if the child has cardiac dysfunction, there is evidence of fluid overload, then definitely you have to go more slow and you have to give it over a period of 48 hours even. And antimicrobials, empirically it has to be started. That depends upon your local antibiogram, whatever the organism, whatever the infections you frequently encounter in your setup. So antibiotics need to be started and they can be de-escalated if you feel once you have reports available. If your patient is relatively stable, he does not have any life-threatening condition, then you can send investigations to rule out infection first, and then you can start again methylprednisolone at the dose of 1 to 2 milligram per kg per day or IVIG. And if the patient does not respond to your first line of treatment, then this IVIG dose can be repeated, or you can give a high dose of methylpred, that is about 10 to 30 they have mentioned, but in the June 2020 update, they have changed it to just 10 milligrams. So it can be given methylpred 1 to 2 milligram. If the child is not responding, then you can increase the dose to up to 10 milligram per kg per day. Then you have to, because if there is cardiac involvement, so and if the coronary artery, this aneurysm Z score is more than 2.5, then aspirin has to be started, provided the platelet count is above 80,000, and it has to be given for at least 4 to 6 weeks. As well as if the coronary Z score is more than 10, or you have any evidence of thromboembolic phenomena, or if the ejection fraction is less than 35%, you have to put the child on enoxaparin for at least 2 weeks. Then for how long the therapy has to be given? For immunomodulator, you can give this high dose steroid for 3 to 5 days, and gradually it has to be taper. You decrease dose 25% every 5 to 6 days, and gradually over a period of 2 to 3 weeks, you can decrease, you can stop the steroids. And with monitoring with not only echocardiography, but also with the biochemical parameters like CRP and D-dimers, you have to look at the trends. If those are improving along with clinical improvement in the child, then gradually you can taper him off steroids. For aspirin, at least 4 to 6 weeks, then you have to get the echo done. You have to look for coronary artery abnormalities, and if it persists, then it has to be given for a further longer period of time. For low molecular weight heparin, again for 2 weeks, and then you have to check in repeat echocardiogram. If this thing persists, the coronary abnormalities and left ventricular dysfunction, it persists, then it has to be given for a prolonged period of time. So if the patient has cardiac dysfunction, you have to give supportive care. Most of them, they do well with fluids, and some may require inotropic support as well. So as the need arises, you have to give a supportive therapy for cardiac dysfunction, and you have to monitor both through echocardiogram about the coronary abnormalities and the left ventricular dysfunction, as well as with the biochemical parameters, and you have to just follow and monitor the child. So the supportive care involves management of shock if the child presents in shock, management of respiratory failure. Some of them require respiratory mechanical ventilation as well, but we could successfully wean them off. Then management of multi-organ dysfunction as the need arises, and gastroprotection. So it depends upon the systemic involvement with which the child has presented, and you have to get a supportive care along with the definitive management with immunomodulators. So the outcomes have been favorable. Fortunately, majority of the cases, they have responded well, provided they have been brought to facility and care has been given to them. And the nature and frequency of long-term complication is now, it's unknown. It's too early to say. We don't know what will happen to such children. We have kept, and I'm sure all of you, all pediatricians who have encountered such cases, you have been keeping such children in close follow-up just to see what coronary abnormalities or what residual disease they have as the future, as the disease evolves. So my take-home message would be MIS is not common, but not so uncommon even, considering today's scenario. Think of common conditions. Once, like recently we had outbreak of cholera-like illness here. So they all presented with gastrointestinal involvement. So think of common conditions, especially in this weather. You get to see a lot of children who have simple rotavirus or simple viral infection presenting as gastrointestinal. So you have to think of common conditions, but at the back of your mind, you should always think of MIS, whether this child can qualify all the criteria for MIS or not. Then you have to investigate judiciously. Does not mean any child who presents with gastroenteritis in the same weather you have reason. Like we had an outbreak, we had close to hundreds of children presenting with gastroenteritis. So you don't keep on sending investigations, D-dimers and serology in all the children. So you have to think, you have to tax your clinical skills, and you have to send the investigations very judiciously, and you have to provide good supportive care, which holds true for any case, and ensure judicious use of medications. So antibiotics, they should not be unnecessarily upgraded and started, because whatever organism are common, you should start with those antibiotics. And outcome, the good thing is outcome is usually favorable. So this is the suggested readings, and that's all for today. Thank you so much. Any questions? I'm happy to answer. So I can't see any questions. So that means, do I proceed? Do we proceed to the next talk? Okay, then thank you, everyone. So for the next talk, we have on PICU management, hand hygiene and general care of patients in PICU. So for this, I would like to invite Dr. Sandhya Chauhan from SRMS Bareilly to proceed with her talk. Thank you so much.
Thank you, ma'am. I'll share my screen. So, a very good afternoon, Dr. Chandrakanta ma'am, all the panelists and the participants. I'm going to talk about general care of a child in pediatric intensive care unit. Okay, so our learning goals going to be, so the learning goals for this session are going to be to learn the importance of supportive care when a child is admitted in pediatric intensive care unit, to learn the components of general care of critically ill child and how to provide the holistic general care. So Once a child is admitted in pediatric intensive care unit, the main goal is early identification of the pathology with which he has been or she has been admitted, to assess the severity with which the child has been admitted, and resuscitation of that critically ill child. So the focus of attention and intervention.
Sorry to interrupt, Dr. Sandhya. People can't hear you. Yeah, your voice is very low. Nobody can hear.
Okay, ma'am. I'll just. Hello. Am I audible now, ma'am?
Better. Can you increase the volume more? Yeah, it's better.
I've increased it to the maximum.
Okay, it's better. Now we can hear you.
Okay.
Thank you.
Okay, so I'll start again. Okay, so when a child is admitted in pediatric intensive care unit, the main goal is early identification, severity assessment, and resuscitation of that critically ill child. And the focus of attention and intervention is basically on the primary or the precipitating disorder. Okay. But one thing that we have to always remember and be aware of, be conscious about, is that intensive care setting in itself is a very hostile and dangerous environment. So, on one hand, where our focus definitely should be managing the primary illness and the severity related to it, on the other hand, we should not forget the basics of routine, supportive and preventive care in intensive care unit. Now, this routine care is standard across the wide spectrum of presenting pathologies. Suppose your patient is mechanically ventilated for a lung pathology, or you have admitted a patient who is suffering with acute kidney injury, or there is a patient having life-threatening MISC. The basic care bundle, if a child is admitted in intensive care unit, has to be followed for each and every patient, and it is more or less the same. So, what is that supportive care? So, once we talk of the supportive care, we are talking of three components.
Hello, Dr. Sandhya. Hello.
Hello, yes, ma'am.
Dr. Sandhya, your voice is volume is low. So, if you can please come close to the device. So,
okay, ma'am. I'll just see to it. Hello. I've increased to the maximum. Am I audible properly now?
Yes, it's better.
Okay, ma'am. I'll try to maintain this. Okay. So once we are talking of monitoring, we are talking of three components. Once we are talking of a supportive care in ICU, we are talking of three components. First is monitoring. Second is prevention of nosocomial infections. And third is ongoing assessment and support. Now, once we are talking of monitoring, we are talking of the key aspects of the patient related to the primary pathology per se. That is the physiological indices, whether the patient is responding to the treatment that you are giving or not, to evaluate whether the patient is improving or deteriorating, and to raise alarms accordingly. And this has been already dealt in the previous lectures. Second component is prevention of nosocomial infections. Now, there is a basic bundle of maneuvers which is practiced in each and every intensive care unit to prevent this. And hand hygiene is the most important component of this bundle. Now, this we will discuss later in this session. Third is the ongoing assessment and support. Now, apart from the basic disease pathology and monitoring its course, this deals with other aspects of patient care, which, if neglected, will not only make the treatment of the basic pathology difficult and complicated, but will also make the treatment costly. Your ICU stay of the patient will be longer, and it may even add substantially to the mortality of the critically sick patients. Okay, so what are these multiple aspects? They can be remembered very easily by using the simple mnemonic FAST HUGS BITS. Now, what you can do is, while listening to this session, what you can do is you make a checklist. You prepare a checklist out of all this of this mnemonic, and this can be used on daily rounds by you, as well as you can train your ICU staff, your nursing staff to use this checklist at the start of every shift to keep a track of the key aspects of the general care of the critically ill patients, and nothing will be left out if you follow this checklist. Okay, so let's see what are the components of this checklist. That is fast hug spit. The F stands for feeding, A is analgesia, S is sedation, T is thromboembolic prophylaxis, H is head of bed elevation, U is stress ulcer prevention, G is glucose control, S is spontaneous breathing trial, B is bowel regime, I is indwelling catheter removal, and D is de-escalation of antibiotics. Okay, out of all these components, spontaneous breathing trial has already been dealt in the previous lectures on mechanical ventilation. So here we'll take others one by one. So starting with feeding. Now, several RCTs have shown that early feeding reduces the incidence of morbidity and mortality in ICUs by improving wound healing, by attenuating the loss due to metabolic stress response, by improving GI function and integrity. Not only does this help in improving the nutritional status of your sick patient, it also reduces the complications and the length of stay in pediatric intensive care unit. Now, how much calories should be given? How do you plan that? Now, remember, in the acute phase of illness, this is not decided by RDA, that is recommended daily allowance, but is decided by REE, that is resting energy expenditure. The energy intake that you are providing, it should not exceed this REE. Now, there are certain formulas to calculate this, or if we just restrict ourselves to a target between 27 to 58 kilocalories per kg per day, we'll be providing the energy intake according to REE in that critically sick patient. The protein goal has to be restricted to 1.5 gram per kg per day. Here, one thing you have to remember, that the caloric requirement increases if the patient is suffering with fever, or is a patient of burns, having sepsis, trauma, or activity. Okay. Now, what are the modes of this feeding? So this can be enteral or parenteral. Enteral, where GI tract is directly used to deliver nutrients and calories either orally or through NG/OG tube, is superior to and is the preferred one as compared to parenteral nutrition, where nutrients are delivered directly into a vein. And this is for obvious reasons, as we can see that enteral feeding is more physiological, has a trophic effect on gut mucosa. It helps to prevent bacterial translocation, thereby decreasing the incidence of sepsis. It's simple, cheap, easy to administer, is associated with very few metabolic complications. It does have a set of disadvantages, like if there is NG tube displacement, risk of aspiration increases, there can be feed intolerance. But we resort to parenteral feeding only if there are contraindications present for enteral feeding, like GI bleed, patient is having gastrointestinal bleed, or the pathology has led to a gut ischemia in that patient, or patient is a case of intestinal perforation or obstruction. Only in these cases do we resort to parenteral feeding, because it has a lot of disadvantages, like it is non-physiological, is expensive, requires venous access, and thereby it increases the incidence of sepsis. Requires frequent monitoring because it has a lot of metabolic complications associated with it. Okay, so how do we go ahead with this feeding? For that, what you can do is you assess for any contraindication for enteral feeding, as I just told, like bleeding or gut ischemia or intestinal obstruction or perforation. You just assess your patient for that. Look for the presence of bowel sounds. If there are no contraindications present, if bowel sounds are present, you can start enteral feeds within 24 to 48 hours of admission, keeping in check to keep the head end of the patient elevated. Once you're going to start the enteral feed, assess your patient for the presence of risk factors for aspiration. For this will decide whether you will go ahead with nasogastric feeding or post-pyloric feeding, which are the two modes again present, the ways in which you can give enteral feed to your patient. If risk factors for aspiration like severe respiratory distress, recurrent vomiting, gastroesophageal reflux with history of aspiration, or delayed gastric emptying, if they are present, you will go ahead with post-pyloric feeding. If they are absent, you can very well go ahead with nasogastric feeding. Now, nasogastric feeding is normally given as bolus feeding, in the form of bolus feeding, where we start with 25% of the target volume on a 2 to 4 hourly basis. Now, what does that mean? Let's take an example. Suppose if you have a 10 kg weight child and you have decided that you have kept a caloric goal, suppose of 500 kilocalories to be given in 24 hours, and the volume that you have decided is 500 ml. Now what you will do, this is the target volume. 500 ml is your target volume which you have to give in order to fulfill the nutrient requirements of the patient, of your 10 kg weight child. Now you will start with 25% of this target volume. Now 25% of 500 ml. This will amount to somewhere near 125 ml or 120 ml. Now this 120 ml has to be divided into smaller volumes which can be given at 4 hourly intervals. So in 24 hours you will be needing 6 such feeds. So the amounts 120 divided by 6, it will be 20 ml 4 hourly. So you start with this. Now you have given your patient 2 to 3 such feeds at 4 hourly intervals, and you find that your patient is tolerating. So what we can do is then we can plan for feed advancement. We can increase the feed again at a rate of 25% increment over the start volume. Now your start volume was 20 ml. So 25% increment of this 20 ml would be somewhere at 5 ml. Na? So 20 ml will increase to 25 ml. Again you will be giving 25 ml 4 hourly. 2 or 3 such feeds. Your patient tolerated. Again you go ahead with the increment of 25%. Suppose next volume is 30 ml. Then 35, and you'll go on increasing if your patient goes on tolerating till the target volume of 500 ml in 24 hours is achieved. Similarly, in continuous feeding, what you do, you start with a start volume of 1 to 2 ml per kg per hour. Suppose we take the same child, 10 kg weight. So the starting volume would be somewhere between 10 to 20 ml per kg per hour. Maximum you can go up to 25 ml per hour. Again, you will go, if your patient goes on tolerating, you will go on increasing this continuous feed volume at a rate of 1 to 2 ml per kg every 2 to 8 hourly, depending upon whether your patient is tolerating or not. And you will go on increasing till the target volume is achieved, which in less than 1 year child is 5 ml per kg per hour, and in more than 1 year child it is somewhere between 5 to 20 ml per kg per hour. Okay. One thing more that you have to pay attention to is, while you are planning for feed advancement, you have to check pre-feed gastric residual volume. Now what is this? Your patient would be either having an OG or an NG tube. Suppose at 8 a.m. you have planned that now my patient is tolerating, and the next feed, that is at 12 noon that I'll be giving, it will be an increased feed. So what you do at 12 noon, before giving an increased feed, you will first aspirate with the help of a 10 ml syringe or a 20 ml syringe very softly. How much is the gastric residual volume? How much volume is still there in the stomach? This is the pre-feed. You have not given the next feed at 12 noon. You have tried to aspirate that you had given a feed at 8 a.m. and now how much is there in the stomach still? This is the pre-feed gastric residual volume. Suppose if you're given a previous feed of 20 ml and the pre-feed gastric residual volume at 12 noon, it comes out to be 15 ml. Now it is more than half of the previous feed volume. You will have to hold the next feed. Suppose your volume was higher, so if the gastric residual volume is more than 150 ml or more than 5 ml per kg, you will have to hold the next feed. Patient is not responding, you can go ahead with prokinetics in the form of metoclopramide or domperidone at a dose of 0.2 milligram per kg per dose, 8 hourly you can repeat. Still your patient is not responding, you will go ahead with smaller volume frequent feeds, that is 20 ml 4 hourly can be broken down to 10 ml 2 hourly or 5 ml hourly feeds. Okay. What should be the composition of feeds? It should be such as to meet the needs of the critically ill child, which in up to 6 months is breast milk or expressed breast milk or formula feed. In 1 to 10 years child, it can be normally milk-based feeds are preferred, but it can be dal or porridge also. If you want to increase the caloric density, you can just fortify this feed with the help of MCT oil, sugar or puffed rice. Take care for the supplementation of vitamins and minerals in their recommended daily allowance, either IV or orally. You can even take the help of a dietitian to take care of the needs of your children in PICU. Now, once the acute phase of illness is over, that is by 7th to 10th day of illness, you'll have to increase the caloric delivery to more than 50% from the present value in order to avoid underfeeding and thereby ensuing malnutrition in the patient. Okay. Next, we'll be talking about sedation and analgesia. Now, critically ill patients, once admitted in pediatric intensive care unit, they often require complex medical procedures, frequent invasive testings, and thus it is necessitated to have a provision of adequate analgesia and sedation in the ICUs, which will not only decrease the pain but will also decrease the stress response. Now, always remember, these agents have to be used judiciously, intermittently, and with frequent monitoring of patients, because where under sedation will lead to stress with long-term consequences, over sedation will lead to need for prolonged respiratory support and prolonged ICU stay. Analgesia and sedation, they are normally preferred over neuromuscular blockade, again for the same reason, because they are quickly reversible and they allow for neurological monitoring. While selecting the agent for sedation, select agents, such agents which have minimal effect on the vital parameters, especially blood pressure. Agents which are normally preferred are short-acting benzodiazepines, midazolam, dose of 0.1 milligram per kg bolus. That's the first dose that is given, followed by infusion. The dose can vary between 1 to 10 microgram per kg per minute. You start with the lowest dose, and depending upon your requirement, you can increase and go up to 10 microgram per kg per minute. Fentanyl is used for analgesia in a dose of 1 microgram per kg bolus, followed by 1 to 5 microgram per kg per hour infusion. For pediatric ARDS, these agents, again I'll repeat, they should be used in their minimal possible dose for the maximum desirable effect. Okay. If sedatives are not completely effective, we'll go ahead with using neuromuscular blocking agents. The drug which is preferred is vecuronium in a dose of 0.15 milligram per kg, followed by 15 to 25 microgram per kg per minute. In moderate to severe acute respiratory distress syndrome in pediatrics, neuromuscular blocking agents, they improve tolerance to mechanical ventilation by eliminating ventilator-patient dysynchrony. They also help in optimizing oxygen delivery by facilitating gas exchange. But their use has its own limitations in the form of profound muscle weakness. So again, they should be used in their minimal possible dose, along with observing a daily neuromuscular blockade holiday of at least 1 hour in order to monitor patients for clinical movement and development of critical illness polyneuropathy. Okay. Next is glucose control. In critically ill patients, a blood glucose abnormality, especially hyperglycemia, is common, it being a stress hormone response. Or there are other things also that are going on while the patient is in pediatric intensive care unit, or with the pathology. The pathology of the patient per se has led to peripheral insulin resistance, or because you are using additional medications like steroids or exogenous dextrose administration. This all can lead to hyperglycemia. Now, both the duration of hyperglycemia and the index of variability of glucose levels, especially the peak glucose level, they are independently associated with mortality. By increasing the need of inotropic agents, they increase the need for mechanical ventilation. They also increase the risk of infection. Now, normally, all the ICUs, they follow the protocol of testing blood glucose level at the time of admission. If normal, then continuing it with monitoring at 12-hourly interval. Any abnormal reading will thus is again followed by more frequent monitoring at the rate of 2 to 4 hourly interval. Now, what is the aim? The aim is to maintain the blood glucose level to a value less than 150 milligram per deciliter. Now, again, it has to be remembered that aggressive attempts of lowering the blood glucose level or keeping a tighter glucose control can lead to hypoglycemia, which is equally deleterious. Now, your aim should be moderate glycemic control, which should be high enough to avoid hypoglycemia and low enough to avoid excessive catabolism, ketoacidosis, hypermetabolism, hyperosmolarity, or risk of infection. Any blood glucose level of more than 180 milligram per deciliter, your first step would be to reduce the glucose infusion rates, whatever you are giving. If the patient is not responding, definitely you will go ahead with insulin infusion. Next is pressure sores. They are common in PICU incidences. 26%. Common sites are occipital region, nose, chin, neck, heel, and sacrum. Risk factors in ICU like mechanical ventilation, hypotension, HFO, malnutrition, sensory loss, dependent edema, central line in the neck, length of stay of more than 96 hours. These are all the risk factors for pressure sores. How can you prevent that? By regularly examining the skin. Train your nursing staff for doing this. Train your nursing staff to practice frequent change of the position of the patient every 2 to 4 hourly. Provide adequate nutrition to the patient. Keep the sheets dry and wrinkle free, and alternatively you can use these pressure mattresses as shown here in the photograph. Okay, before I show you the photographs of the stages, we'll just go ahead theoretically with them. These are the stages of pressure sores. Stage 1 is where the patient is having intact skin with non-blanchable redness, and the management is protective dressing. Stage 2 is shallow open ulcer with red-pink wound. Here, management is clean the wound with saline and water and then apply moist dressing such as transparent film or hydrocolloid dressing or hydrogel, foam, alginate dressing, etc. Stage 3 is full thickness tissue loss with visible subcutaneous fat. Stage 4 is full thickness tissue loss with exposed muscle and bone. In both these two conditions, if necrotic tissue is present, then you will have to perform debridement. If not, then clean the wound and apply moist to absorbent dressing. Unstageable, this is one stage of pressure sore where full thickness tissue loss is there with base of the ulcer covered with slough and eschar. And there is another suspected deep injury where the patient will present to you with purple maroon localized area of discolored intact skin or blood filled blister, and you cannot just assess what is below that. Whenever necrotic tissue is present, perform debridement and then followed by cleaning the wound and applying moist to absorbent dressing. Okay, so here you can see in this photograph, this is of stage 1 non-blanchable erythema of intact skin, the pinkish, the erythema you can see here. Stage 2 is partial thickness skin loss with exposed dermis, pinkish wound, yellow dermis. This is full thickness skin loss with muscle and bone exposed. Stage 3, this is basically the dermis which is visible. Subcutaneous fat is visible here. Here it is, in this stage, it is skin and tissue loss along with there is muscle and bone which is visible beneath. This is the unstageable ulcer where a necrotic tissue, lot of necrotic tissue is present and there will be full thickness skin and tissue loss. Okay, next, eye care. Now, our ocular surface is normally protected by our ability to produce tears, to blink, to close eyes with rest or sleep. Now, you just imagine, recall what all things you do in intensive care unit. What are you doing? You are giving oxygen, either with the help of oxygen mask or CPAP. Now, this gas flow, this has a drying effect on the corneal surface. You sedate the patient, obviously for the benefit of the patient, but sedation reduces the blink reflex. You use muscle relaxants, they decrease the ability to close eyes, leading to lack of thalamus. If your patient already has suffered with a neurological insult and you have admitted for that in the pediatric intensive care unit, this insult will further reduce the protective mechanisms of the eyes. So all the things, all the mechanisms that we are using for the benefit of the patient in pediatric intensive care unit, they are increasing the risk of developing ocular surface abnormalities in the form of exposure keratitis, corneal ulceration, infection, and it is seen in quarter of the patients. So what you can do is use lubricating ointments, artificial tears to keep cornea and conjunctiva wet. You can use 1 drop every 6 hourly in both the eyes. If eyes are not fully closed, you can use protective eye taping as is shown in photograph here. It is very effective in preventing corneal erosion. And in cases of infection, definitely you will go ahead with using antibiotic eye drops. Okay. Next is oral hygiene. Now, again, critically ill children, they may not be able to maintain their oral hygiene and normal saliva production due to, again, numerous maneuvers that we are doing in ICU, like we are using sedation, fluid restriction, we are keeping the patient nil orally. There is no diet that is going through the oral cavity. Drugs, we are using drugs that may exacerbate xerostomia. All these lead to accumulation of dental plaques and tongue coating, thereby predisposing the oral cavity to colonization by drug-resistant organisms. These form a very important source of ventilator-associated pneumonia, and therefore regular cleaning of the oral cavity, especially in the intubated kids, is very essential. You can use antiseptic solutions like chlorhexidine for this purpose. Care has to be taken that while cleaning, you have to ensure that the dislodged plaques and secretions, they are not aspirated. So for that, keep the head end of the patient elevated, endotracheal tube cuff should be kept inflated, closed suction should be used as far as possible. Okay, NHS GGC pediatric clinical guidelines, they are giving us a format of how to take care of the oral cavity while the patient is in PICU. And for this protocol purpose, they have divided the pediatric patients into 3 groups. One is neonates and infants less than 1 year with no teeth. Second is infants and children 1 to 3 years with teeth, and children more than 3 years with teeth. So how do you begin? First, you ensure that the head end of the bed is elevated before giving any oral care. It should be elevated to at least 30 degrees. Wash and dry your hands, don disposable gloves. You can use a lot of assessment tools available online for staging at what level of care the oral cavity of the patient requires. Now, once we go ahead with the management, in neonates and infants without teeth, the main aim is to keep the oral mucosa moistened. And this has to be done every 2 to 4 hourly. So what do? We wrap a swab moistened with sterile water or saline around our gloved finger and wipe the gums and mucosa with swab to moisten the mouth and apply yellow soft paraffin to lips. And this procedure has to be repeated every 2 to 4 hourly. In the second group of infants and children with teeth, between 1 to 3 years with teeth, this 2 to 4 hourly maneuver of keeping the oral mucosa and the lips moistened has to be practiced. Along with that, another thing which is added is brushing of the teeth with soft small headed toothbrush and a smear of fluoride toothpaste every 12 hourly. This has to be done. In children more than 3 years with teeth, 2 to 4 hourly moistening of the oral mucosa is practiced. Along with that, 12 hourly brushing of the teeth is practiced. And the third component which is added is that 30 minutes after tooth brushing, you apply 1% chlorhexidine gluconate gel to foam stick and wipe the oral mucosa, teeth and gums with that. Do not rinse or moisten the mouth with water following this. Okay. Next is stress ulcers prophylaxis. Now, critically ill sick patients, critically ill children suffering with especially hypovolemia or decreased cardiac output or having a lot of pro-inflammatory cytokine release, they are normally predisposed to acute gastric ulcers because of decreased mucosal blood flow or decreased GI motility. Now, these ulcers can lead to upper GI bleeding if the risk factors like thrombocytopenia, coagulopathy, organ failure, mechanical ventilation and with the use of high pressures, shock, prolonged surgery or steroid is there in the patient. Normally, stress ulcer prophylaxis are not routinely advised because literature suggests that it may increase the risk of nosocomial infections. What you have to do is be cautious, observe for the color and the volume of the nasogastric aspirates. If the volume increases, color is brownish or blackish. This is suggesting of that there is this is the indication for gastrointestinal bleeding, and then definitely you will go ahead with using drugs like ranitidine or sucralfate or PPIs like pantoprazole. Next is thromboembolic prophylaxis. Now, venous thromboembolism is increasingly being recognized in children due to the presence of risk factors like secondary to illness, their primary illness with which they have been admitted, age is less than 1 year, more than 14 years, they have undergone some recent surgery, suffering with complex medical conditions like malignancy, chronic cardiac disease or chronic renal disease. Prolonged hospitalization is there, or they have have inherited or acquired thrombophilia. Now, central venous catheter is the most common risk factor for this thromboembolism. Now, what we have to do is strict monitoring of the clinical signs and symptoms of VTE should be done in children. Since most pediatric VTEs are catheter related, so they can be located either in the upper venous system or in the lower venous system. In the upper venous system, they will give rise to swelling, pain, discoloration in the upper extremity. If in the lower venous system, they will give rise to abdominal, inguinal or leg pain, swelling, bluish purple discoloration in the lower extremity. If suspected, Doppler venous ultrasound is the commonest modality for diagnosing VTE in children. Now, standard unfractionated heparin or low molecular weight heparin prophylaxis is not routinely advised, but since we are talking of severe COVID-19 and MISC, this definitely has an indication. If your patient has definitive evidence of thrombosis, or the D-dimer values are more than 5 times upper limit of normal, or the patient has been diagnosed to be having giant aneurysm with absolute coronary diameter of more than 8 millimeter, or the coronary aneurysm score is Z-score is more than 10, or left ventricular ejection fraction is less than 30%, these are the indications for using low molecular weight heparin or enoxaparin. Contraindications are marked thrombocytopenia, platelet count of less than 25,000 per microliter, hypofibrinogenemia, that is fibrinogen activity of less than 100 milligram per deciliter, if the patient is a case of end-stage renal disease, or patient is suffering with recent major bleeding. Duration is until at least 2 weeks after discharge from hospital. We can resort to longer outpatient therapeutic enoxaparin if these indications are present. And what are these? If the coronary aneurysm score is more than 10, treatment would be indefinite. If the patient has documented thrombosis, though 3 months pending thrombus resolution, for 3 months pending thrombus resolution, that is after thrombus resolution, 3 months, till 3 months we continue the treatment. Ongoing moderate to severe left ventricular dysfunction, in these cases again indefinite treatment with enoxaparin can be continued. Doses in neonate 2 milligram per kg twice daily subcutaneously. In 1 month old, it is 1.5 milligram per kg twice daily subcutaneously. In 2 months to 17 years, it is 1 milligram per kg twice daily subcutaneously. Remove the central venous line associated with VT as soon as possible. Okay. Ensure follow-up for diagnosis. You have done a first ultrasound. Now, you have to ensure follow-up ultrasounds also in order to screen whether your VT is decreasing or increasing. Other maneuvers like early mobilization and physiotherapy, use of compression devices, stockings, it can be used. Okay, another drug which we can use for thromboembolic prophylaxis is aspirin. Conditions like thrombosis or coronary aneurysm score of more than 2.5 Z-score, here aspirin can be used in a dose of 3 milligram per kg per day to 5 milligram per kg per day. Duration is until normalization of platelet count and confirmed normal coronary arteries at more than 4 weeks after diagnosis. And the contraindications are active bleeding, significant bleeding risk, or the platelet count of less than 80,000 per microliter. Okay. Next is care of lines. Now, once a patient is admitted in PICU, a lot of lines are there, like intravenous lines, central lines, you put chest tubes, you put PD catheters. All these lines, they are important source of nosocomial infections, and therefore they have to be observed very carefully. You have to train your staff to observe them. Like we'll start with IV cannula. You have to train your staff to examine it at least once per shift for phlebitis. You have to train them that every time they are giving bolus injections, or they are checking the IV flow rates, or they are changing the solution containers, the cannula site has to be observed. Now, we have an objective assessment scale of for these IV sites, assessment for these IV sites and intervention. This is known as visual infusion phlebitis scale, and this is like this. It has score from 0 to 5. A score 0 is where the site appears healthy, there is no sign of phlebitis, and you just observe the cannula every shift. Score 1, if one of the following is present, like either the patient is having slight pain or there is slight redness, these are the possible first signs of phlebitis. Observe for the changes that will further occur. If it is score 2, that is 2 of the following are evident, that is either there is pain at IV site plus swelling, or there is swelling plus erythema, or there is pain at IV site plus erythema, this is the early stage of phlebitis. You have to remove the cannula, change the site of the cannula. In score 3, all the signs, pain, induration, erythema, everything is present. This is intermediate stage of phlebitis. Remove the cannula, change the site, and consider treatment in the form of limb elevation using an anti-inflammatory analgesic like ibuprofen, making the patient wear compression stockings at that site. In score 4, all signs are evident and extensive. There is pain, induration, erythema. Along with that, there is palpable venous cord. This is the advanced stage of phlebitis, or we can say this is the early phase of thrombophlebitis. Remove the cannula, change the site, consider treatment in the form of limb elevation using an anti-inflammatory analgesic like ibuprofen, wearing compression stockings, and also you can use thrombophobe, which is a composition having benzyl nicotinate and heparin. If you apply it locally on the skin, it not only dissolves the clot present superficially near the skin, but will also relieve the pain and inflammation by increasing the blood flow. In score 5, all are evident. Along with that, your patient will develop pyrexia. This is the established phase of thrombophlebitis. Remove the cannula, change the site, use everything that I've already told, and this is a definite indication to initiate antibiotics. Okay, in the central venous line, monitored regularly for displacement, bleeding, patency, infection of a hematoma formation at the site. Remove as soon as no longer needed, or your patient develops fever with no obvious foci. In case of chest strains, assess periodically for movement of the fluid column, amount and nature of drainage that is coming in the ICD bag, displacement, breath sounds, and subcutaneous emphysema. In PD catheter, monitor the patency of the dialysis catheter and the flow rate regularly. Remove as early as possible after the peritoneal dialysis is completed, and never forget to send the PD fluid and catheter for culture. Okay. Next is chest physiotherapy. Now, critical illness in itself, followed by the intubation that your patient is undergoing, mechanical ventilation, supine position of the patient in ICU. This can lead to deleterious effect on the lungs due to decreased cough reflex, decreased mucociliary clearance, sequestration of secretions, or decrease in the lung compliance, etc. Here, chest physiotherapy plays a very important role in restoring lung health by increasing the drainage of secretions, improving ventilation perfusion matching, decreasing the work of breathing, and increasing functional residual capacity. Now, as shown in the photograph here, this can be achieved by using percussions or vibrations in various positions, as you can see here. Okay. The practice of prone position in ventilated children. Now, this has been seen to increase oxygenation in the early stage of ARDS. It increases in ventilation perfusion matching. It enables the drainage of secretion, this position, and it also has been seen to improve lymphatic drainage. So indications are, it can be used in cases of severe ARDS or children with severe COVID or non-intubated children, and its effectiveness is being still investigated in moderate cases. Now, once you plan to practice this positioning, this chart will show you there are 6 positions in which it has to be practiced. First is it begins by lying in prone position, then lying to your right side, then sitting up, then lying to your left side, then in semi-prone position, and then returning to the proning position. All these positions have to be practiced on a flat bed for at least 30 minutes to 2 hours. At the complete of the cycle, again a new cycle will begin. Okay, so the key messages are, we have to recognize that holistic care is needed for a critically ill child, and it's very easy to remember all the components of this care by this mnemonic: FAST, HUG, SPIT. Use it to prepare a checklist. Train your staff to use that checklist at the start of every shift. As far as possible, practice minimal sedation and plan for early extubation if you want to improve the outcome of your pediatric intensive care unit patients. Nutritional support is equally important for early recovery. Physiotherapy done regularly not only helps to prevent sores but also improves the lung health, and always follow the dictum, first do no harm. These are the suggested references, and these are the skills that we have just read. Now, going with the second part of this presentation, this is asepsis in pediatric, how to maintain asepsis in pediatric intensive care unit. Okay, and the learning goals are going to be, we have to know what healthcare associated infections are, what are the common HAIs, how to maintain strict asepsis in our wards and minimize common HAIs, learn the importance of hand hygiene and prevention of the VAP ventilator associated pneumonia, that is to know about the VAP bundle. Okay, so what are HAIs? Now, CTC defines that any clinical infection, whether localized or systemic, that was not present at the time of admission, this is HAIs. These form a major cause of mortality and morbidity in ICUs. Nearly 1/3 of the critically ill patients, they suffer with this, and they are of 3 categories. One is bloodstream infection, second is VAP, ventilator associated pneumonia, and third is catheter associated urinary tract infection. What are the risk factors? Age, less than 1 year. Prolonged stay in ICU is a very important risk factor. Severity of illness at the time of admission definitely plays a role. While in ICU, prolonged stay, prolonged use of sedation, broad spectrum antibiotic usage. These are very important predisposing factors for HAIs. Pre-existing medical condition definitely can play a role, and use of invasive devices. I've earlier told they are very important source for nosocomial infection. So all these things increase the risk of acquiring HAIs while the patient is in ICU. Can we reduce it? Definitely yes, by following a 4-pronged standard precaution: safe injection practices, use of personal protective equipment, practicing respiratory or cough etiquette, and most important, hand hygiene. Okay, now here you can see I've placed 2 charts there. They are online available. You can download them and display these posters near the hand washing area. Now the first one is of hand wash. The entire procedure has 11 steps, has to be practiced for at least 60 seconds. You can use soap or chlorhexidine and alcohol containing hand wash. This poster shows of the steps of hand rub. There are 8 steps, have to be practiced for at least 30 seconds. And you can use 0.5% chlorhexidine with 70% ethanol for doing this. You can download these posters, display at the near the hand wash area so that everybody can practice accordingly. Now, these are the 5 moments of hand hygiene which has been recognized by WHO. Now, all of us, before we enter the pediatric intensive care unit, the intensive care setting, we are in a habit of washing our hands. But what this slide tells you is, once you have entered the pediatric intensive care unit, suppose there are 5 beds or 10 beds in your pediatric intensive care unit, now at every bed you have to practice these 5 moments. What are these 5 moments? Before patient contact, you have to practice hand wash or hand rub, whatever you have planned. If you are performing examination of the patient, before that aseptic task, you have again to wash your hands. Suppose the patient has a Euro bag or ICD bag which is there and you have examined it, then after body fluid exposure risk, you have to wash your hands. Fourth is, after you have completed that patient contact, you are through with it, examining the files and all, you have to practice hand wash. And after you have left the patient surroundings, you have to practice hand hygiene. And these 5 moments have to be practiced at each and every bed. Okay. Next is personal protective equipment. Gowns, gloves, mask. These are the clothing or devices donned for safety or protection while performing hazardous patient activity in order to interrupt disease transmission. Everybody must know proper donning and doffing, especially doffing, which is very notorious, more notorious than donning in spreading this contamination. Respiratory etiquette or cough hygiene. To cover one's mouth while coughing, not with the hand but using your upper arm. Disposing of tissues appropriately, following hand hygiene practices after touching the respiratory secretions. This respiratory etiquette has to be followed. Safe injection practices, like before applying any, if giving any injection, clean the area with alcohol swab, use single dose vials, single-use needles. The use of single-use needles should be practiced in intensive care units. You can also display posters and distribute it to the attendants about minimizing the visits and other relevant cares, like before entering they should remove their slippers and shoes, ornaments, wash the hands, rub hands before touching anything, do not sit on the bed, don't touch anything in ICU. All displaying all these, you can have posters and just you can display. If you are around allowing parents inside the intensive care unit, they should be donned with adequate PPE. Explain clearly that all these precautions are taken in the best interest of their and other children in the intensive care unit. Another important component is the proper disposal of biomedical waste. Should be practiced very religiously in the ICUs if you want to prevent HAIs from occurring. Disinfection and sterilization of intensive care unit and instrument, it should be practiced. Record should be there on this and this date, this has been done, and the next due date is everything should be displayed. Time to time, culture audit of the admitted patient should be done. You have to send cultures not only from the patient or from the instruments, from the walls of the ICU, from the ceiling, from suction pipe, other areas during regular surveillance, so that you know the whole profile of contamination in your intensive care unit. As far as possible, use the antibiotics very rationally. How to prevent bloodstream infections? By using central lines made of Teflon and polyurethane, using minimum number of ports. Insertion should be done under aseptic precautions with scrub up to elbow. Use of universal precautions should be practiced. Drapes over the patient. Skin antisepsis should be practiced with either 2% chlorhexidine or 10% povidone iodine. Use sterile gauze and transparent semi-permeable dressings. Antiseptic ointment should never be used at the site of insertion. Be in a habit of changing the IV fluid administration sets every 72 to 96 hours. Disposable pressure transducers for CVP or APG monitoring, they should be changed every 72 to 96 hours. How can you prevent UTI? By placing the catheter aseptically. It should not be placed if there is no indication. Closed drainage system should be used. If contaminated, replace it immediately. Catheter should not be irrigated unless absolutely necessary. Proper hand hygiene and aseptic precautions must be used when handling the catheter. Junction between the catheter and the drainage system should be secured properly and should be removed. The catheter, the Foley catheter, you remove as soon as possible. Okay. Next is ventilator associated pneumonia. This is new onset of pneumonia after 48 hours of mechanical ventilation, and it is the second most common healthcare associated infection. Incidence is 20 to 36%. It is associated with high mortality, morbidity, increased length of PICU stay, hospital stay, excessive antibiotic usage, which in future will lead to antibiotic resistance. Endotracheal intubation is the most important risk factor, which increases the risk of VAP by 6 to 20 folds. Etiologies are hospital-acquired pathogens can lead to it, Acinetobacter species, Pseudomonas aeruginosa, Klebsiella species, E. coli, or methicillin-resistant Staph aureus. All these agents can lead to it. How can you prevent it? By two-prong approach. Practice the general measures to prevent HAI, and then there are specific measures to prevent the VAP in the form of VAP bundle, which has 6 components, and I'll take one by one. First is items to prevent iatrogenic spread of infection that I've already told. If you adhere to good hand hygiene practices, definitely you will be preventing the iatrogenic spread of infection. Use of universal precautions. Use of appropriate isolation techniques based on infectious organism. Second is items to prevent aspiration of gastric contents. Again, elevate the head of bed to 30 to 45 degrees. Monitor the or drain the excess gastric contents and avoid gastric distension. Third component is how to improve oral hygiene. That also I have told you earlier. Oral rinsing or cleaning with chlorhexidine has to be practiced. Use of toothbrush, and you practice the whole oral care bundle that we have already discussed. Fourth is items to decrease the endotracheal tube risk factors, like use of inline suction equipment where appropriate and available. Suction of hypopharynx should be done prior to ET suctioning and repositioning. Maintain the endotracheal tube cuff pressure and avoid unplanned extubation so that you don't have to re-intubate the patient and thereby increasing the chance of infection. So plan it very properly. Fifth is items to avoid contamination of the respiratory equipment that you are using for the patient. Like there should be a dedicated oropharyngeal suction equipment per patient. If the patient is on mechanical ventilation, you prevent the accumulation of respiratory circuit condensate in the respiratory circuit that you are using. Prevention of contamination of ventilation equipment. Change of circuits only when visibly soiled or malfunctioning should be done. Use only sterile fluids in the humidifiers and for nebulization per se. The sixth component is how to items to decrease the duration of mechanical ventilation. Shorter the duration of mechanical ventilation, shorter the lesser would be the chances of your patient acquiring VAP. So for that, practice neuromuscular blockade holidays for 1 hour every day. Stop them. Assess your patient whether your patient is ready for extubation or not. Minimal sedation should be practiced. Daily assessment should be done of the patient for his readiness to extubate. Appropriate levels of sedation should be maintained such that ideally the child is awake but comfortable. Over-sedation will definitely lead to weaning failure. Continuous heavy sedation should be avoided as this depresses cuff reflex and spontaneous ventilation, and also predisposes to aspiration of oropharyngeal contents or secretions. Okay, so the take-home messages: understand the importance of hand hygiene, practice the measures for prevention of common healthcare associated infections, and practice VAP bundle. So these are the suggested references, and my sincere thanks to all the contributors of this presentation. Thank you.
So, thank you, Dr. Sandhya, for such a wonderful presentation.
Thank you.
So, have any questions? I can't see any questions. So, do we move to the post-test now? I think we are done for the day. The organizers?
Yes, ma'am.
Okay.
Thank you, Dr. Aisha, for sparing your time, and thanks a lot.
Okay, thank you.
And my special thanks to all the speakers. They have done wonderful job, and they are taking lectures back to back for now more than 2 months. So I'm very thankful to all the speakers, and my sincere thanks to DGME sir and Dr. Shaili Avasti ma'am, our HOD, and for their constant support for this training program. And I thank Dr. CEO, Mr. Neeraj, and Mamta team for all the technical support. So now Mr. Neeraj.
Hello. Actually, hope there's a network problem with Dr. Chandrakanta, I think. So I'm continuing with explaining how to go through the post-test link. So I'm sharing my screen. This is basically a sample prototype of a message what you have received today regarding the link of the training and YouTube link. Second, the third one is basically your post-test link. It will be activated on 3:30. So as we the process is same as what we have followed in the pre-test. If you have already clicked on this link, so I request you to please close that tab on your browser or Chrome or whatever browser you're using. You have to click on the link when it is activated so that your general details will come pre-filled. So I'm taking 1 more minute to explain it. So this was basically the message, and what we got here is the Google link for the post test for the day 4. So I'm also showing you in sample how it will look in basically just wait. Just 1 second. I'll take few seconds. Okay. Okay. You'll be seeing this message has been dropped on your inbox in the WhatsApp. So if you're not able to see this link completely, you have to click on this read more. After that, you have to click on this link. Okay, you can also use the link which is shared with you on the day 1, which contains basically links for day 2, day 3, day 4, and at last there is a link of the post test. Both links are same. So I'll be activating the link, and the link will be active for 20 minutes. You have to submit your post test within 20 minutes. If you face any issue, you can WhatsApp me on the number from which you're receiving these messages for the training and pre-post test. So just please, once I'll inform that it is activated, you have to click on the link. The link is activated now. You all can go through the post test. If you face any issue, you can WhatsApp me on the number from which you are receiving these links. The link is started. Please go through the post test. You have 20 minutes. The link will be closed on 3:50. Thank you. Dr. Sumesh, you have to click on that link again as you have clicked previously when the link is not activated. So you have to click on that link again so that all the details will come pre-filled. This is for all those who are facing this issue regarding the participant ID. You have to click on the link when it is activated, and it is activated just now. So if you have clicked previously, close the tab and click on the link again. Those who are facing any issue with the test, they can WhatsApp me on the number from which you all have received the links for the test. Thank you, everyone. Closing the meeting, those who have submitted their post-test certificate will be shared with them. We usually take 7 days, but we'll try to share by today. Thank you. Closing the meeting, and the link is closed for all. Thank you.